There'll obviously be
instructions set up to find information on its favorite. There's sort of but I'll right, we might make a start. Yeah.
they are.
We know. Oh, what
So we worked together about that, right? There's even less people behind us. And so nobody's really left. Yes. We were just having a discussion on the train on the way. Coffee on the route to choose. Which if you look at the scenarios, basically could be catastrophic by 2050. Another 50 years. There's scenarios, but the bottom line is kind of which is going to have real like cities that are just filled with he's now crossing the net for them and shuffling around the city with seniors, used to be children and families. So this is a real.
I'm trying to send her any emails.
Like migrant birth rates match. That's been sustained in every yeah.
She copied mine.
Well,
yes, they can hear us.
Spelled slightly differently.
We have a very jam-packed morning ahead of us, so we're going to try to be on time. I just note for all the speakers this morning, we think the benefit of this session today will be lots of small pieces of information, except for Ethos. We have we're indulging ourselves today, and an opportunity then hopefully for the audience to connect during the break for those of you here and those online to connect offline if you want to ask more questions. So there will be some Q&A at the end. So welcome to our Heat Health Research and Treatment case, which is co-hosted by the Queensland Heat Health Community of Practice, which for many of you online you will be familiar with. We're really happy to see so many people online from all of Queensland and some other states of Australia. So the QHHCoP has been running for a couple of years now, and we are really proud to be able to run these events from time to time and bring the heat health community together to share resources, have a dialogue around heat health and how we can promote action in Queensland. So acknowledging my co-lead, Tony Matthews, here in the audience.
Morning all.
I'm not sure if you can see the camera, but that's okay. And also acknowledging a wonderful advisory group, and some of the advisory group members are here, and I'm hoping some will be online. I haven't had a quick look online. The advisory group comes from different levels of government and other research institutions, and some consulting groups, and it's really a really great group that gets together and helps us work out what might be of interest to this bigger community of practice. So co-hosted by that as a kind of a way of showcasing some of the heat health research that is going on and will continue to go on. Also co-hosted by the Ethos project, which is a Wellcome funded Griffith project. We're taking the liberty of having a session today that's a little bit longer than everyone else's. This is the end of our project, so we wanted to take the chance to kind of spend a little bit more time. Some of you have probably seen some of our presentations in other forums, but we just really wanted to get some of the work that we've done out there and to acknowledge the team and the process that we've gone through and our partners along the way. So welcome again to those in the room and also to those online. I'd also like to pay my respects and acknowledge the many lands of which we're meeting both in Queensland and across Australia, and pay our respect to the elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islanders who may be engaging with us today. So I've already done the welcome and introductions. Those of you who are online, please feel free to use the chat and connect. We find that that's a really nice way catching up with people maybe you haven't seen before or asking questions. We won't have a lot of time for questions, but we will take questions on notice. And if there's any specific ones for speakers, we'll pass them on to the speakers. And we do have some time right at the end of the morning session to have a bit more of a discussion, and some of those key things that you're really burning questions we'll hopefully be able to talk about. So I'm also chairing the first session, so I'm going to be the mean person who shuts you down when you're gone over. Sorry about that. But also some of the team in the front here have some signs. So we're looking at a 7-second sort of run at the end. So those of you who are presenting for the sign for Matt, who has a sign. And I'm now going to introduce myself. So we wanted to talk today about our Extreme Heat and Older Persons project. It's been going on for about 3.5 years now. We wrap up our formal funding in a few weeks, and I'd just like to, on behalf of the leadership team, Sebastian Binglis, who's in Germany right now, and Aaron Bates, who can't make it this morning but will be here later this afternoon. We're going to present across the three of us today, myself, Fergus O'Connor, who's another member of our team, and Steve Baker, both key members of our team. And we have other members today too. So if you haven't met Mahak and Ella and Erica before, please do make sure you introduce yourselves. This is what we're going to talk about. We're quite a big team. We have multiple part of our team. You can see you can see how the diversity of the types of disciplines that are involved in our team. And so we spent a lot of time working together, learning about each other's worlds, and that's been a really valuable experience. We're supported by a great steering committee who span health policy, practice, disaster policy, climate policy, aged care, and some other peak bodies and consultants engaged in technology, and also professionals from the health sector. We've also been incredibly supported, and we're going to have a whole session this afternoon to talk through this with the Ethos team, but of a reference group of older adults, and a number of them are in the audience. And my special thanks to them this morning in this audience. We could not have done, I think, such a successful research project without the input of our reference group. So I'd just like to acknowledge that work as well. Okay, so we set out many years ago to develop a digital, individualised in-home heat health early warning system, and that's a bit of a mouthful. We do know that there are existing early warning systems in place, but this is the first time, at least in the Australian context, that we wanted to consider how we could take the early warning system theories and take them into a more of an individualised in-home setting. And we were funded to look at that in the context of Queensland, with the goal of thinking how this might be useful to other locations and other populations. And that's kind of where we're up right now. So we've got now a concept and we'll work through that. So we set up a project with three kind of core themes: care systems and user experience, technology development, and heat preparedness and response. And I think a lot of our work is focused around those three kind of constructs. We focused on older people. Those of you who are here probably understand why older people as an at-risk population are incredibly important. Besides the physiology changes that occurs as we age, and we're all aging, we also acknowledge that multi-morbidities that occur when we age may make us more at risk of heat because of exacerbation of those conditions, that we have medications that we take related to those multi-morbidities that also can make us more thermally sensitive to the extreme heat. Thermal perception changes, and we also know there's a lot of socioeconomic issues that occur as we age that might make us more at risk because of social isolation, poor quality housing, and lack of resources to respond to extreme heat. And coinciding with that, of course, is that we are getting older, so there's a larger percentage of us who are over 65, or we want to live at home as well. So we want to live at home, so how do we actually encourage people to live at home safely as we age? So we've adapted some of the theories from digital technologies for ageing in place, which is a whole field of research that some people in our team are more across than I. And when we started looking into it, it was very clear that there were recurring themes of independence, dignity, and willingness to learn. So as a pretty big and growing at-risk population, it was really imperative that we worked with older people to develop solutions that would work for that population. So we were working with this particular group. We wrote the early warning systems framework, which is as a response to climate and extreme heat across the world. So there's a lot more investment now for early warning systems for all. And that's a large collaboration between WHO and WMO. So that's a useful frame for that. We know that population-based early warning systems don't always work. They fail for a number of reasons. They are a good strategy for what we have, but they make assumptions about what we're actually exposed to, and we know that often indoor temperatures are quite different. They're not always, the warnings are not always heard or communicated in a way that is understood. For example, I still watch Jenny Woodward on the Nick Weather. Some of you will not even know who I'm talking about. And the ABC, for example, will publish the extreme warning events and the maps of Queensland. Which other ones do? I don't know, because I don't watch any of the other channels. But there's 2 points. Do people hear the warnings, and then do they understand what they are? Do we know what a low intensity versus a severe intensity warning is? And so there's still challenges around that. Our current systems make major assumptions about susceptibility and, who are thermally at risk, physically at risk, and they can't put all that diversity that exists in our populations. And I guess the other thing that we've tried to do is think a bit more about the cooling recommendations that are made and tailoring them more to the individual. So, people, especially older people, and I guess the best example is water-based cooling. One lady who was 100 said, I would never take, when we asked them, would you have ice in your freezer? I would never take water from my sink to my freezer because I'd be worried about spilling it, which would lead to falls. So understanding not only what works, but what is going to be used and will be effective for that population was critical to thinking about that tailoring of cooling in our system. So drawing on the early warning system framework, we developed this kind of piece of work around thinking about what the risk knowledge was in this group, how we could monitor the in-home conditions, developing a risk algorithm, which takes the environmental monitoring data, it takes some individual characteristics which we know make people more at risk and puts them into a core temperature prediction. And we've used a heat balance model and then advance that through machine learning. It then needs to obviously communicate some type of risk or alert to the individual. There's various ways we've done that, which we'll explain a bit later. And obviously the system is only as good as the ability of the user to respond. So thinking about what that response capacity was. And we're very much focused on individual capability. The ability to engage these types of systems into the more formal care system is something that will hopefully evolve as this work occurs. But at the moment, we're very much focused on individual empowerment at the household level. We've done lots of work. We can't really summarise it in 30 minutes, but we did a lot of work up front. We did a lab survey, survey around, I think, 547. We thought very clearly and carefully about how all the people would engage with a survey. So we did both a paper-based and an online version. We did world cafes where we spoke in this very room. Some of you might have been here with policymakers and older people and researchers to really understand the issues around this topic. And then we established our reference group and our steering committee to help us with providing advice along the way. And we also, of course, had to think about the technology, both the software available and also the technology and the hardware that was available. See, I know about things like hardware now. I never knew about I'm certainly not a techie person. And along the way, we then drew on our expertise in our group to co-design our hardware and our user interface. We developed a machine learning algorithm, and we did a lot of communications, both to improve awareness of this topic with the sort of assumption that people would not even be interested in engaging in our research if they didn't think this was a problem for them. So we did create a series of videos which some people have used across the country to help raise awareness of this issue for older people. And we worked really hard to then also promote our work and recruit to our trials. So we've, over 2 seasons, we've monitored around 130 homes across Southeast Queensland. We've done some work before and after to better understand cooling behaviours, value proposition of this technology, preparedness for extreme heat, knowledge around heat risk. We've done focus groups to work more carefully with those in-home participants, and some of them are here today, which is fantastic. Hopefully some are also online. And of course, worked hard to communicate some of those findings. And here we are now at the end of our project, and we have a whole heap of outputs that Steve's going to talk about. And so we see this as just a great foundation for a platform to move ahead. It may not necessarily always look like a tech solution, but certainly we believe we've got a good momentum and good partnerships to look at how we can heat health in our state. So I'm going to hand over to Fergus to talk about some of the system and what we found so far. Thanks, Fergus.
Thanks, Shannon. So as Shannon briefly touched on earlier, we developed an individualised early warning system. Essentially, the goal was to increase heat awareness, increase personal heat risk perception, preparedness, and change cooling behaviours within our population group. And we aim to do this by real-time monitoring of temperature and humidity in 3 in-home sensor locations and 1 outdoor location. So as Shannon touched on, the model worked by basically a predicted change in core temperature, and that was derived from personal characteristics such as height, weight, and gender primarily, and obviously the temperature and humidity within a given room of the household. So we had 3 indoor temperature and humidity sensors. Most dominantly, 1 in the living room, 1 in the main bedroom, and then 1 in a secondary living area, such as a study or a secondary sitting room sort of thing. Once an alert was issued, which the system detected that the predicted change in core temperature was to be of some level of risk if the person stayed in that household location. Without implementing any cooling recommendations, core temperature would increase. Once the system detected that, cooling recommendation, which was tailored to the individual circumstances, whether it be accessible and acceptable to the individual, was recommended. And this is what the alert looked like. In this instance, it's an amber alert, so the risk level was estimated to be medium. Once the alert came up, the individual on the base station, which is a tablet format, the individual had the opportunity to click a drop-down menu which detailed the recommended cooling interventions based on their acceptability to that individual and also the effectiveness of the intervention. So we can see ranking order by most effective to least effective. Obviously, taking a cool bath is the most effective way to cool down rapidly. However, this may not be acceptable to all individuals. If the intervention was not acceptable to the individual, it would not be listed in that drop-down menu of promoted interventions. So this is how the system worked in the first summer period, where all the communication was linked back to the base station, which, as I say, is essentially a tablet that sat on a convenient location where visible in the household. Most people seem to have it on their dresser or a side table, something like that. In the second summer, we basically wanted to see if we could use this infrastructure and roll it out in an app format. So we essentially removed the base station or the tablet that sat visible for the individual in the household, and everything was communicated via an app. All the software and all the work in the background was pretty much, well, exactly the same, but like I say, communicated through an app. This is how the app looked. Warnings were issued in the same manner, but directly to the app, and individuals could access the list of cooling interventions and some information about when to use the cooling intervention and so forth. If they were to click on it on one of the little drop-down arrows, they could see the temperature and humidity of a given room in the household in real time, whether they were in the house or down at the shops or wherever they may be. So, touching on some of the survey findings from 2022. So before we rolled out the system, as Shannon touched on, surveyed nearly 550 older Queenslanders about their heat health knowledge and heat health perception, and also their current heat protective behaviours. So we can see here, I guess, some quite, in some instances, striking findings and general lack of awareness in some cases. Air conditioning use, pretty similar to state averages with prevalence of air conditioning, and very little information provided by healthcare professionals to our population sample that their age makes them sensitive to the heat. We also conducted some world cafes. I was involved in the second one, not the first one. This is Ella's PhD work, I believe. No, it's not Ella's PhD work. This is Ella's work. It's not my particular area of research, so I can't talk in a great detail to the World Cafe, but we essentially brought key stakeholders into the room, this room in particular, and discussed heat health knowledge and heat health risk perception and so forth. Some key findings of the World Cafe's challenges with heat wave communication, which Shannon touched on earlier. Messages are being sent out, but they're not always being heard. And obviously a message that isn't heard is essentially meaningless. Older adults know what to do during heat waves and hot weather, but several barriers prevent action. In particular, access to cooling, environmental support, financial constraints, cooling key barriers. Obviously, I'm sure everyone in the room can appreciate cost of electricity at the moment. And if you're running your air conditioner, particularly in southeast Queensland, and even today where it's you can certainly start to feel the temperature rising. If you're running your air conditioner for, let's say, 1/3 of the year flat out, the financial implications can be quite significant at the end of the summer. Psychosocial and physiological factors also influence whether someone feels at risk or takes action to prevent negative heat health impacts. So this is the in-home trials when we actually implemented and put the system in people's homes. In phase 1, we had 78 households, and in phase 2, we had 63 households across southeast Queensland. So as far south as Coolangatta, bordering on Tweed. And did we end up further north in Brisbane? Yeah. So quite a widespread across southeast Queensland. The mean age of participants was, low to mid 70s, with a significant range. And across the 2 summers, we had 141 total households. As I said earlier, in phase 1, we were implementing the tablet-based system. In phase 2 was the app-based system. We collected pre and post intervention implementation surveys to assess the change in heat risk knowledge, perception, and change in behaviour of participants since using the Ethos system. Also their user experience, whether or not they actually liked using the system in the different formats, the app or the tablet-based system. And also during the trial, to understand the cooling behaviours of participants when risk was increased. So when the system sent an alert to a participant and said, you should use a cooling intervention, on a day that occurred, on the evening of when that alert was issued, they were then sent a follow-up survey that said, first and foremost, did you see the alert? And second of all, if you did, what did you do about it? What cooling interventions did you use, if any? And we obviously monitored temperature and humidity, as I touched on, and we also recorded some physiological metrics as well by Fitbit, solely within the second summer, looking at changes in activity levels, sleep quality, and some physiological markers as well. In phase one, we saw nearly 2,500 yellow alerts, so where the system predicted that the level of risk was medium for these individuals, in contrast to 88 red alerts were high risk in the 78 households monitored. And we can see the average number of days of alerts, and you can see where the red bars overlaying on the figure, which were severe or extreme heatwave days called by the BOM. So the system is obviously, assuringly, at least predicting more alerts on those days where heatwave. And that's me. Hand over to Steve.
Thanks, Fergus. So in the next couple of slides, I've got the sort of pleasure of talking about some of the impacts and outputs. So obviously, having heard from Shannon and Fergus, it's really, really clear about the extensive work that's gone into developing the Ethos system and the survey and World Cafe and how that's informed the way we think about extreme heat and older adults. But it's very, very important for us, and especially, I suppose, at this time in the project as we're sort of coming towards that sort of final phase, to really think about what impact that's had and what the outputs from the project have been so far. So I'm going to speak a little bit to that in the next couple of slides. There's quite a lot of information on this slide. I'm going to unpack that a little bit for you. But I suppose there's a couple of impacts I want to speak about in this sort of cluster here. One is that the statewide survey data has really improved our understanding of how old adults view extreme heat, how they view heat health risks, and their views on the role that technology can play as a tool to inform responding to the impacts of heat health. And we know that work, I'm going to speak a little bit about some of the academic outputs in a moment, but we know that work is going to be really, really valuable in terms of informing policy, not just here in Queensland, but really throughout Australia as heat becomes more of a factor. Through the development of the Ethos early warning system, really, really importantly, since we now have 2 summers of trialling the system, and as Fergus spoke about, we've got we had the tablet-based system, and we've also tested it as a mobile app. We've now got really strong data collected over multiple summers that demonstrates that we have a robust, minimum viable product is the term. It's a bit of an odd tech term, but yeah, that we know we have a product that works and that can be adapted for use. And that's a really, really important output from the project going forward, that we know that we've sort of been able to demonstrate that product works, and importantly, that the people using the product have reported back to us that they were really satisfied with it. And we've got really great user satisfaction data from the product to know that people really responded well to using the product. They felt it was reliable and easy to use, which is really, really important. And then I suppose summarising some of these other points in this slide, through the work we've now got a really strong evidence base to support the fact that the Ethos early warning system improves heat health knowledge, that it improves our temporal awareness of heat risks, and importantly, that technology and knowledge and awareness translates to behaviour change, because ultimately, having a system that feeds you back information is all well and good, but we really wanted to make sure that translated into actual meaningful behaviour change as well. And we know that that's also accompanied by a measurable shift in risk perception as well, which is a really, really great output from the project. In terms of the sort of more academic side of the outputs from the project, there's currently 5 published papers. There's 2 that are under review looking at technology management and cooling behaviours. We've got 1 in preparation for the World Cafe. There's 1 published manuscript in the Journal of Thermal Biology. We've got 1 in preparation around app versus tablet. You can see there's a concept manuscript that was published in Nature Digital Medicine. We have another publication in Nature Climate Change, thank you. There's in preparation is also a transdisciplinary research manuscript. And, as Shannon was saying at the beginning of our presentation, one of the really strong aspects of this project, and something that I know I've really gathered, I've gained a lot from as a researcher, has been just the fact that the Ethos team is such a diverse team of academics working from different discipline bases. And the fact that we're all able to come together, and it's this is down to the key members of the Ethos team, both the leadership team and some of the team in front of me here, Mahak and Ella and Erica, that there's been a really, really strong connection between all of us. We've been able to meet together and learn from each other's and our perspectives that our different disciplines bring. So it's really, really great that there's going to be a paper that speaks to what we've learned from that process. And I think particularly in the Australian research space at the moment, there's a lot of interest in that interdisciplinary and transdisciplinary research. So we really feel as though that's going to make a really strong contribution to the field as well. There's a couple of other things there, a manuscript on cooling, acceptability and accessibility that's under review. We've got a manuscript on household exposure, and another 2 manuscripts under review around sleep and the physiology and Fitbit data. So in the second season, when we had the app, we also had some participants wearing the Fitbit to get additional data. So that's being developed as well. So I guess the takeaway from this is we're all very, very busily working on making sure that there is a lot of papers that are translating from this that can inform both policy, but also research into heat health moving forward, which is fantastic. And then in terms of outputs on the sort of traditional, non-traditional space, a really, really fantastic aspect of the project has been the fact that in addition to the academic outputs that have flowed from the project, there's been really, really strong communication and translation as well in terms of non-traditional outputs. So I'll speak to sort of some of those here. We've got the Ethos website where we've got a range of reports that have been published through that, including a survey technical report, a survey policy report, the World Cafe reports, and the key takeaways from the international symposium that was held here in September, August, time flies. There's been, as you can see, a lot of work from the team in presenting about the Ethos project at a range of different conferences. I won't go through all of them there, but as you can see, and again, this speaks to the transdisciplinary nature of the project, the Ethos project has been sort of spreading far and wide in terms of presenting at different forums, both in Australia and throughout the world. And then there's sort of the wider engagement that the team, particularly in the front here, I want to give a shout out to Ella, to Mahak and to Erica. There's been really, really strong communication throughout the project. And I think it's a really, really fantastic aspect of the project that there's been such strong engagement with the community through the project as well. And you can see there noted on there is an awful lot of engagement through blog posts, through communication, through seniors magazines, through the conversation website, all sorts of different outputs there that have been speaking about heat health and about the Ethos project more broadly to the Queensland and Australian population, which has been fantastic. And then finally here, just want to talk a little bit about the videos, and you can see the 3 videos on the right-hand side there and links to them. These were developed in the sort of first couple of years of the project. Many of you may have seen these, but if not, I really, really strongly recommend that you engage with them. These have been fantastic communication just around improving our awareness of how of heat health impacts for older adults. And I know, I can give you a little anecdote here, that I know that these are translating into the broader community, because I have elderly parents who are living in a retirement community in regional Victoria, just in Horsham. And about 3 or 4 weeks ago, my father called me and he said, "Do you work on a project about heat at Griffith?" I said, "Yes, I do." And he said, "Oh, we had a nurse come from Grampians Health today who was speaking to us because we're preparing for the Victorian summer, and was speaking to us about making sure that we were prepared in the heat. And she showed us these great videos." And so the Ethos videos were played, and my father sort of picked up on the fact that it came from Griffith. And even though my parents don't really know much about what I do, they knew that that was associated with that. So that was a really, really lovely thing to be able to feed back to the team that, you know, as far-flung as sort of regional Victoria, these videos are being adopted by other health agencies and actually being used as a communication tool. So that's really, really fantastic and a really lovely output from the project, and a real credit to the team, I think.
So just one point, and Danielle's here. Danielle has a project, and there's 2. These videos are also now being translated into 2 other languages now. So that's a really good outcome.
It's fantastic. Okay, I'm going to pass back over to Shannon now to wrap things up.
Thank you, Steve. That was great. And I'm not going to talk too long because we're already being forward. I'm not going to talk about that. So I guess in conclusion, I'm really excited to be standing here with such a strong foundation. I think we've done a lot of work to establish the value proposition of this type of system. I think we've also worked really hard to better understand what drives action in our older population. We're still doing a lot of work, as Steve has alluded to do those more analysis and get some more of this work out there. And so hopefully that will be coming. We will hope to keep our website alive for quite a bit longer. It will be transferring to another home, but that will be seamless. No one from the community will probably see that. We are working with partners around pathways for engagement with aged care and healthcare, and we're very open to anyone who has any ideas to come and talk to us. So we've had lots of conversations about that, but please do come and talk to us. We are interested in doing some of this work with other populations, and we have some potential relationships around mental health and also looking at disability. Both populations have conditions that make them more susceptible to extreme heat and may also benefit from a system like this. So we're exploring that. We've started to work with thinking about the utilisation of this type of system in other contexts, and we currently have, it's pleased to say that our system is being used in social housing in Singapore, in an older aged social housing multi-storey complex, no air conditioning. Now you imagine living in Singapore with air conditioning and being older, that would be interesting. So hopefully our system can help that population, and we'll be certainly working with our partners there. The Ethos system is also a set of components. So how each of those components could individually contribute. So the monitoring component, the alerting component, the cooling. So we designed it as a system. However, parts of that system could be utilised as well. And that's something we're exploring, as well as whether there's value of commercialising and making this more available. And part of that might be also working with aged care communities about integrate better into digital technologies in home situations. So that's what I wanted to talk about today. Thank you very much to the team. We are out of time, but we're all here today. So if you have any questions or want to see your lunch, please do come and see us. And those of you online, thank you. And please send us any questions. Fantastic. Thank you. Is Tony Matthews. Dr. Tony Matthews is a academic at Griffith, working in urban planning and climate, and he's been working with us on a number of heat projects over the years. So he's been
Am I on the desktop here?
you should it so it's all in the chat. So you will see that just everything there. Thank you. Some technical difficulties.
Yeah. Being true to the issue. I think it's not an issue. Yeah, because that's what it's in chat. Yeah.
Okay, wonderful. Thanks to Ella for solving our technical problems. Not for the first time and definitely probably not for the last. Morning, everybody. A pleasure to see so many of you in person, and welcome also to our friends online. It's great to have these events. And I've already had talks with people this morning about how good it is to see people in person. I'm Dr. Tony Matthews. I'm an urban and environmental planner in the most basic terms, and also the QHHCoP, or the Queensland Heat Health Community of Practice co-lead with Shannon. And very happy to see the QHHCoP doing so well. We're nearly, 3 years now? 3 years since we launched, and growing all the time and building membership. So wonderful. Thank you all for your enthusiasm and participation in that. I have lots I could talk to you about today, but I'm going to talk to you instead about the only, it's called the HEAT tool. It's the output of a project that has completed. If you know us, you know we like acronyms. So here's another one to get your head around. This is HEAT, the Hybrid Environmental Design Auditing Tool. So this is basically a very, very sophisticated tool that anybody can use because it's largely non-technical with the right training. And the other great thing about the tool is it's completely free to anyone that wants it. We developed it as part of this Queensland Government SAP Plus co-investment project back a few years ago, and part of our agreement with the government as funding agency and also with the department was that we would make the tool available to all stakeholders at the end of the project, and so we have. In fact, we made it available about 2 years ago. My chief investigators or co-investigators on that project, you can see them there for yourself, some great people. Claudia Baldwin, who's mostly retired now. Chris Boulton, who's with Sunshine Coast these days, I think, and Sylvia Tavares, who's still above at the University of the Sunshine Coast and doing good work there in heat monitoring. Some of you probably know Sylvia. What HEAT delivers basically is it's a very comprehensive integrated tool that we developed that brings together a whole bunch of strategies for measuring urban cooling as a baseline, for measuring crime prevention through environmental design as a baseline, SEPTED, for those of you that are familiar with the terminology, and also for measuring universal design principles. So what it really does is it offers a very sophisticated way of doing on-the-ground assessments of current baselines around cooling, shading, design, wayfinding, safety, sociability, rest points, all sorts of things that you would need in a good quality environment where you're trying to ameliorate or offset heat in the atmosphere. Particularly, we're talking outside, by the way. I should stress that the HEAT is specifically designed for outdoor areas. So it's a very comprehensive auditing tool, as you'll see in a while. So it does that, it audits, which is great. It also allows then a baseline and a platform from which to develop targeted intervention. And we have worked with partners on that to varying degrees of articulation, like right up to full site scale plans and solutions, down to sort of just general suggestions for areas. One of the things that we will do with the HEAT and that anyone can do with it and probably should do with it is it works up to about district scale. So you could even potentially do something like, say, South Bank from bridge to bridge from here to the other side. But what you would have to do is break it down into subsectors. The resolution of the analysis breaks down at a certain spatial scale. So you might have to break that down into maybe 10 or 12 subsectors and look at each one individually. That's the way that it works at, say, a hospital or an aged care. Both areas extensively tested the tool and refined it. So it can be scaled up or down from a single site to a large campus, but if you're doing a large area, you'll subdivide it into single sites anyway. And it's also very cost effective because it costs almost nothing to do a survey. little bit of equipment cost. You can even borrow the equipment if you know the right people, or you could buy the equipment if you're planning on doing multiple surveys, say you're a landscape architecture firm or something like that. You decide to take this too long. You can just buy the basic equipment and then use the stuff indefinitely. It's not expensive. It can be expensive if you hire me to do it, and if you hire me to give you sophisticated, costed, and effective design interventions and suggestions, that can be expensive. But to do an audit on your own, not so much. But you might be thinking, well, why use it? Well, it's great for dealing with heat stress in outdoor locations, particularly with vulnerable cohorts. We, as I say, specifically looked at the cases of aged care and hospital patients to develop the tool. Now, we weren't just thinking about the residents either, we were also thinking about the staff. So there's a huge problem with staff retention. For example, in aged care facilities, it's a high burnout kind of a field. So we took the idea that, well, if staff were able to take their breaks in nice, pleasant, outdoor, shaded, naturally ventilated areas, instead of indoor windowless, air-conditioned rooms with buzzing lights, it might help a little, maybe. So we were thinking about the experience of staff as well, and also the experience of wider families, people that come to visit these facilities and how long they'll stay and so on. So focused on heat stress, but particularly with a mind to vulnerable cohorts. And then with many, many benefits for different space providers, be they aged care providers or local councils who are doing public space design, or somebody who's designing a school campus or a university or anything like that. There are multiple places where this can be used, but because it brings in both universal design and CEPTED, it has this kind of cross-cutting accessibility side to it, which is really great. Some of what it does and allows for measuring heat and humidity in external areas. Now we can do that either as a single point measurement or interval measurements or longitudinal. We have done all. And the longitudinal stuff, of course, helps us refine the strategy because anyone who works with heat sensors will tell you that a lot depends on where they're located and so on. So sometimes they have to be shifted around or the batteries fail or all kinds of things happen. It allows for an integrated assessment of cooling, accessibility and personal safety because all of those things are assessed at once. As part of the survey. It's very good at helping to generate strategies and ideas for interventions, everything from a sort of a maintenance-based intervention to something involving a lot of capital works and expense and in between. And very often when it comes to improving outdoor environments, particularly for thermal performance, it's just a few maintenance changes will make a significant difference. You can usually get like an 80% improvement with 20% effort. It's the last 20% is when you have to spend the big money usually. Oftentimes, understandably, people don't want to do that. On-site stakeholders can be consulted on designs. Yes, you can do that like at any stage with the tool, either when you're doing auditing or if you're forecasting future design interventions. You can talk to the space users as another part of information collecting. Like, obviously, we don't ignore that. You can work without them, but I wouldn't recommend it. And then there's different implementation horizons and different cost horizons and different activity horizons and so on. I won't spend too long on this because I'll show you some imagery. This is just one bit of the tool, all right? It looks complicated. It's not. Once you've been trained to use it, it's dead easy. So what I would say is that the work is in the training. The cost is potentially in the training. You don't actually even need official training. You can just read, figure it out for yourself. But if you really want to learn how to use it like in the most sophisticated way, it's best to do a couple of hours training with us, and then you can have at it from there on. So it looks complicated and kind of is, but it shakes down into very clear information over time. These are just some examples of like basic summaries that we've done where we made some observations and suggested some priority actions. And we looked at some of the highlights as in the high performing features of these areas that were already in place. Forgive all the blue lines, I had to de-identify this. This was commercial work, so I had to make sure you couldn't see who it was for. But you can also see there on the pictures that we have used a subsector approach. As you can see there, we have subsectors A to F, I think, in this one, and this isn't even a particularly large facility. But once you start thinking about microclimates and use and orientation and build quality, or sorry, not build quality, but when places were built and so on and so forth, it all starts to make sense to use a sectoral approach. These are other outputs that we produced for a separate client who wanted something that was a bit more like this. Where we did our auditing and presented it a little bit more visually and then suggested in text-based terms some of our other ideas around that. And again, bear in mind, each one of these is just for one sub-area, of which there were probably 6 or 8 or possibly 10 in the whole facility. So we produced an entire audit of the facility done area by area and then looked at interventions for each area and also across areas. And you can see there, of course, we some of the most revealing things that you'll find when it comes to checking for heat are when you use a thermal camera and you realize that, you know, the places where people are supposed to sit to degrees Celsius and this kind of thing. So that's one of the parts of our tool as well. Thank you, Mahan. So we have a proven track record. I'll keep this quick because I'm coming to the end on this one and I want to stay in time. And we have a proven track record. We developed and tested it in collaboration with aged care facilities across both Southeast Queensland and also the tropical areas of far North Queensland, varying in climate scale and urban density. We looked at 10 plus sites during the R&D phase, including established aged care facilities, the kind of low-rise ones, moving to the newer high-rise formulation and morphology and everything in between. We also looked at a hospital and we visited an aged care facility in FNQ that was specifically for Indigenous people and worked with them as well. We've employed it commercially since. There is a more sophisticated version of the tool for commercial use. There's a basic one freely available, more sophisticated one for commercial use. Lots of people could be interested in using it and might find benefit with it. You can see them listed there. And as I said earlier, you can do your own analysis, you can commission analysis, or you can ask for training so that you can do it yourself, or you can just take it on yourself. As I said, the information is freely available and I'm happy to direct you towards it afterwards. So I'll leave it there. If you do want any further information or the tool or reading on it, just drop me an email. It's probably the fastest thing, or we'll chat at morning tea. Okay, thanks everybody.
Thank you. Okay, really interesting. I really enjoy watching the outputs of your work. So now we're going to online and we have Monique Lewis, Dr. Monique Lewis, who is going to be talking about her work on heat disability and communications.
Hi,
And
everyone.
hello. Now, what are we doing here, Ella? Will I stop sharing this screen?
She should be, I'm just going to spotlight her so that we can see her. And then could be able to.
Do I need to stop screen?
Yes, stop sharing. Okay, well, spotlight.
I did my best.
Oh, I'm huge. No. I wish I hadn't seen that.
It's all right. You got the mark.
I'll get over it. It's all right. I'm just going to share my screen. So hopefully it will. Let me see. I'm hoping it's going to share my PowerPoint. Sorry about the dog.
We can see your screen, but just not your PowerPoint.
Can you see it now?
We can. Yep. I'm going to leave it to it.
Okay, excellent. Everyone can hear me okay. Let me know. Just interrupt, yell out if anything doesn't work or you can't hear anything. And I apologize. For some reason, neighbours are just deciding to do lots of noisy stuff as it happens. So thanks very much for inviting me to present today. Thanks, Shannon. This is based on some research. I'm a media and framing scholar, so I teach into media and communication at Griffith University. So this is a study that's really kind of zooming in on representations of disability in news reports about heat waves in Australia. And the collaborators on this are the fabulous Shannon, the fabulous Professor Elizabeth Kendall, Katie Ellis from Curtin University, Hannah Adler and Hannah Revell, who are all from Griffith University. So climate-related disasters and extreme weather events, we know they don't impact everyone equally. There's been a lack of attention to the rights of people with disabilities in climate change research and the climate impact on disability groups. Despite being one of the largest marginalised groups, people with disability are often not considered in research and policy making about sustainability and disaster resilience. So news reporting plays quite a crucial role for many people during extreme weather events, including for people with disability, and it can reflect and shape attitudes and beliefs about disability. We know news does this, and it can really influence the visibility and voices of people with disabilities through how they're framed, the stories that are told, the sources of information used, the spokespeople that are included in the stories. So This study is sort of looking at these news representations and heat waves in on the ABC Online and news.com.au. Go to the next one. So the journalism profession is starting to address heat waves. So there's leading agencies like the Reuters Institute for the Study of Journalism that are kind of focusing on it as a specific concern facing journalists who need to know how to respond to and report on it. So the Reuters Institute made heat the focus of their annual networking event in 2024, identifying the lack of heat wave reporting in news coverage, the invisibility of heat as the silent killer, which poses problems for news platforms which are really highly visually oriented, the delayed availability of morbidity data, the need to address basic literacy about extreme heat events in newsrooms, etc. And Shannon brought to my attention the Earth Journalism Network recently hosted a similar event focusing on heat. The Global Heat Health Information Network has a document giving guidelines for journalists on reporting heat. And this document, like many climate change risk-related documents I've come across, doesn't specifically address people with disability as an at-risk group. So rather, they might refer to chronic medical conditions or limited mobility and mental illness. And there's been, there's a lot of work increasingly happening in this space with disability research scholars, one of whom is Michelle Villeneuve, who works a lot in inclusivity of disability in disaster planning. Some of you may be familiar with her work. And sort of drawing on the Archbishop Desmond Tutu's concept of adaptation, climate adaptation apartheid, the exclusions the exclusions of people with disability highlight what Walbring referred to as adaptation disableism, so emphasising those inequities in climate adaptation support processes for people with disability. News is an important medium to consider. We understand it's pervasive, it's powerful, plays an important role in the power relations and how disability gets viewed, how it gets perceived, how it gets constructed. And we're looking at how disability is shaped in this study, which investigates how these reports portray and construct disability. This is just the method. So these were the data came from ABC Online, news stories, news.com.au. The time period was 1st of December 2023 to November 2024. The search terms covered heat and risk and disability and heat, and we coded content for the themes that arose, the sources used in the stories, and the disability media models and framings that arose. I'm just checking my time. Okay. The disability models, and again, this is going into critical disability studies work, but a number of you, if you've worked in this space, may be familiar with these. So it's based on the work of Clogston and Beth Haller, who came up with these models. Katie Ellis has contributed to these as well. So you have the medical model of disability, which sees disability as an illness or problem to be cured. So on the left, you can see the more traditional old-fashioned models, like the supercrip model. We often see commentary along the lines of, overcoming all odds and heroes by hope. So at Paralympics, you can often see journalism lapse into that kind of inspirational tropes. There's the social pathology charity model, so seeing people with disability as disadvantaged, in need of charity or saving. The business model might frame accessibility as not profitable, as negative impact, having disability having a negative impact on business because accessibility costs money. So then you have the more progressive models, which are minority and civil rights. So disability framed in terms of disability advocacy they're a minority group with legitimate grievances and have active demands for political change. There's the cultural pluralism model, which looks at, disability is just one part of the whole that makes up the individual. So people with disability in this mode are more likely to be seen as autonomous, independent and capable, full members of society. There's the legal model, which is focusing on disability rights and discrimination with an emphasis on legal protections, and the consumer model, which is you know, it's as one of my PhD students says, my legs may not work, but my credit card does. So accessibility for people with disabilities is profitable to business, maybe an untapped market as well. So the results we came across are 172 reports, 90 in ABC News Online, 85 in news.com.au. We had 3 authors co-coding 20 reports and 1 author completed the remainder of the coding. It's just a little word map. Now I'm going to whiz ahead because we haven't really got time. So these are kind of just, and I'm happy to share this data with you, the themes, what were the prevalent disability models, the news sources, but let's cut to the chase with and visual representations, of course, which is always fascinating. So this is the broad finding across 172 reports, but disability stories, these are the stories where we saw news reports addressing risks for people with disabilities. So I've got them listed here. And so there were 12 stories that directly mentioned disability in relation to heat waves and extreme heat. Only 1 came from news.com.au. The remaining 11 were from ABC. 4 of these mentioned disability more generally and typically addressed it as one of a list of other at-risk groups, including older people, people with chronic illness or medical conditions. There are a number of references to specific disability types, and these included neurodiversity. So one article referenced ADHD, autism, depression and heart conditions. 2 referred to multiple sclerosis. And then we had depression, Ehlers-Danlos syndrome, heart conditions and stroke, which all received 1 mention across the data set. And 9 reports carried the theme, people with disability are at risk. So yeah, just acknowledging all from the ABC. So this story early in the year was a court report piece about the trial of a carer who left a non-verbal Perth man with autism in a car at a shopping centre during a heat wave. So this was the story of an accused carer. You know, he'd abandoned his client in a very hot car, very hot conditions, with the man's family thanking passers-by for rescuing him. So it framed the abandonment of and the negligence towards someone dependent on his carer, emphasising those legal consequences. And it also highlighted the social pathology charity framing of vulnerability, conveying the need for Jefferson Doe's saving by non-disabled others. And you can gather that from some of the quotes there. This story focused on disability, heat, and the impacts of heat on medications. And the story is kind of an informational guide about medicines and heat. It was in January. It focused on heat sensitivity for people with ADHD, which can cause, so the medications can cause heat sensitivity and heat intolerance as a side effect. And this was one of the few reports that went into detail about the risks facing people with disabilities. It also mentioned depression as well as the impact of the sun on a whole list of medicines. It featured the state manager from the Pharmaceutical Society of Victoria. We saw a young person with ADHD who had suffered heat stroke and a senior academic from the New South Wales School of Pharmacy. So primarily we see a personal health management framing here. So focusing on individual medical conditions that need self-management. And we've got this personal anecdote from Tara and a focus here on what individuals can do and expert advice focused on personal responsibility along with behavioural adjustments. So there is quite, you know, we coded this for a cultural pluralism media model of disability because although it was focused on medication and there was an implied underpinning of medicalisation and medical authority, the voice and agency of Tara in this story, the person with ADHD and autism, held too much autonomy for them to be reduced to being simply portrayed as dependent on a hierarchical medical system, unlike the story of Jefferson Doe, for example. Okay, the next story, another story from February. So this was had a minority civil rights model and in terms of disability advocacy, minority groups with legitimate grievances, active demands for political change. So this story focused on heat inequities, the dangers of heat waves. It tells a story, so broader, affordability, housing affordability, social housing as well. It's the story of 60-year-old Susan Jones, who had an acquired neurological disability from an aneurysm and a stroke, living in social housing on the Sunshine Coast. and her health had been drastically affected by the intense humidity, including very humid nights without air conditioning. And the report cites World Health Organization recommendations about keeping homes below 32 degrees in daytime and below 24 degrees at night. So offering voices from scientific authority along with messaging about the known dangers or deaths from heat waves. Another report in August came about at the tail end of winter, with parts of Queensland predicted to have a 36-degree end to the season. I'm not sure if some of you remember that. This report led with the story of Bailey, a person with Ehlers-Danlos syndrome, a condition that makes them unable to regulate their body temperature, which can be fatal. In its positioning of Bailey, the story used a progressive minority civil rights perspective, which presented Bailey's agentic voice, discussing the challenges and fears they face in heat, including the financial challenges and stresses of running an air conditioning system. So following Bailey, we hear from a not-for-profit advocating for affordable, energy efficient homes. And then we heard from a couple of other non-disabled people struggling financially, followed by an urban designer. This story, so in March, going back to March, we found another of the people with disability at risk stories addressing heat inequities, including financial ones and heat morbidity, which drew on the results of a new report that had just been launched by the Australian Council of Social Services, and quoting its CEO. So it's based on a survey of over 1,000 people that found 60% of people were having trouble paying energy bills, and 80% saying heat in their home had made them unwell. And we hear from Donna, a 64-year-old woman who's on a disability pension, who's anxious about becoming homeless. And she speaks of the difficulties she faces financially, as well as trying to stay cool. Another report, and this was earlier in the data from 1st of December 2023. This was an unusual piece, a perspective news piece by Wilde-Liz de Jesu, offering a really frank, embodied account of the personal and physiological impacts of heat that she experienced as a person with MS. And so this was a less traditional, more exceptional piece, highlighting that isolation experienced by many people with disabilities, occurring notably in conjunction with the upcoming International Day of People with Disability. So applying progressive models of cultural pluralism and the minority civil rights model, noting this is a human rights issue. So in this story, heat vulnerability is framed as an opportunity for solidarity and collective action using a first-person empowerment narrative. So this is a really small sample. I'm mindful of that. It's on a very specific, focused climate health issue arising from climate change. The progressive models predominate. We see the minority civil rights, we see cultural pluralism, though social pathology and charity is also present here. This is interesting in how, when we see the voices of disability emerge, there is more autonomy given to those spokespeople. They're able to recount their embodied experiences of heat. They're politically astute often about their rights. So there's quite a bit of activism and advocacy work at play there too. And, I guess a question that might come out of this is what happens when we centre disabled bodies in heat stories, potentially. But just reinforcing across the entire data set, disability visibility was low, but there is a shift in the historical voice or visibility or lack of given to people with disability in these types of stories. Thank you. I think I've lost everyone. Have I lost everyone? Can you hear me? I can't hear any of you right now. Oh, good. Online can hear me. Thanks, Monica. Some lovely comments coming in, but I don't know. We may have lost the room.
You're Shannon.
No, it's just right to you, Tony. Might there be an opportunity to distribute some of this through home nursing services and at least let them know that these things are possible?
Yeah, that's a great idea. Yeah, thank you.
Thank you, Ross.
I'll yield to Monique.
Can have a chat after morning tea, that'd be great. Sorry, we'll just keep going now that it seems like we have a fix. Can you hear us, Monique?
So it was, I think the online crew could hear me, but could no one else, just maybe tell me where I'm up to, or are we done? Am I done? Did everyone hear me?
I'd like to hear a bit more about what you found. We're just going to have to look at our timing. So
No, that's okay. That's fine. Thanks, everyone.
we're just jumping through to your presentation. Going.
Sorry. Here we go.
Oh,
Can you all hear me?
no, we're going to do Monique first. Are we going to finish hers?
She's done with online.
Oh, she's done online. Oh, Monique, it looks like you've done online. So,
Yes, I've reported to all the online people, the most
Okay, all right.
important people.
all right. And isn't that interesting? Often it's the online people who miss out. So in this case, maybe if you've got any questions for Monique, please let us know and we will connect you up to Monique and her work. And she's also presenting in other forums. So even if we've got a PowerPoint we could share with you, might be good. Is that okay, Monique?
Yes, that's fine. Thanks, Shannon.
Thank you. Okay. All right. We'll move on then.
And the
Anna's next.
recording will be available for everyone as well.
Okay.
So hello, thank you all. Thank you all online. Thank you, Monique, as well for taking care of everything while we had to reboot the system. But my name is Ella. I'm one of Monique and Shannon's students doing my PhD on communication for heatwave resilience. But a lot of you guys might also know me from the Ethos project because I work on that, talking to people on the phone and trying to make everyone laugh. And then I also work on the Queensland Heat Health Community of Practice. So you've probably seen a lot of emails from me just sharing events or just saying hello, smiley face, all that sort of stuff. So my PhD is all about how we can improve heatwave communications to help facilitate behavioural change among older adults. So some of, and now I'm having technical difficulties. Okay, so we already know the context. We already know that heat waves are rising. We already know that older generations are increasing as well. And this has significant health impacts, both for the people that suffer them, but then also for people working in the healthcare systems and things like that too. So one of the key problems that my research sort of looks at is the fact that there's a low personal heat health risk perception that exists among older adults. This is not just here in Australia or Queensland. This is seen all over the world. It's a very interesting phenomenon for me personally, because I'm like, how does that happen? And as a result of that, a lot of people, if they don't really feel like they're at risk, they're not going to change their behaviour as a result. So therefore, less likely to adopt any sort of heat protective behaviours and more likely then to have these, negative health outcomes during hot weather. So in my work, looking at how we can improve current heatwave communication strategies, possibly looking at some using behaviour change theories and techniques and things like that to try and help people change their behaviour. So without going into too much detail about the gaps in literature, there is a limited focus on older persons' risk perception, how this influences behavioural adaptation, insufficient integration of behaviour change theories and designing heatwave communication specifically for this cohort, and there's a lack of literature exploring the role of heatwave communications in actually changing behaviour. So my research is looking at 4 different studies. Study number 1 is a systematic literature review where we're looking at what sort of information is out there. Has anyone really been looking at communications and have they changed behaviours amongst older adults across the world? The next one is a news framing analysis. So I can be really quick on that one because I've only got 5 minutes and I don't know how much time I've got left. And then also focus group discussions is study number 3. All of these 3 studies are going to inform study number 4, which will be a World Cafe style. We'll be talking to journalists, older adults, carers, people working in government, things like that too. But it's all going to be informed by the other 3 studies. So some preliminary results for the systematic literature review. Long story short, there's not a lot of information out there. So we were looking at anything published since the year 2000 until 2020. Sorry, till 2024 to see what's out there. Has anyone looked at releasing a heatwave communication or intervention with older adults specifically, and have they looked at whether or not having this communication has actually changed behaviours? And only 7 studies out of 2,344 actually met the inclusion criteria, which wasn't really all that strict in my opinion, but that was all that came. So some key findings across the studies. Effective communication is simple, engaging and personalised, which I think we already know. Next, direct engagement is more effective than just giving, than just giving information and walking away. So that peer-to-peer support or, personal interaction is really important. And also older adults, particularly those with chronic conditions, are less likely to perceive heat risks and adopt protective behaviours as a result. Another very interesting finding. And then I'm going to try really hard to be very quick on this, but I have also been looking at TV news framing analysis since October 23 until March 2025, released in Southeast Queensland, looking at YTV, because 94% of older Queenslanders use this to get heatwave information, according to Charlie. So some very, very, very preliminary findings. From what I've seen, it's a lot of fun in the sun, a lot of people at the beach, a lot of people splashing around in water, having a good time. Ice cream comes up every single time. It's really, really interesting. Next, kids and bomb. Every single one has the bomb. They're talking about, yeah, we've got some hot weather coming, blah, 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 blah. And they always talk to children as well. I don't know why, but almost everyone, they talk to children as well.
They're into the ice cream.
Yeah.
And they're splashing in the pool.
And then in the very small number of times, so it's approximately like 37%. I did the maths. I'm not very good at maths, but I did it. When there is a call to action at the end, sometimes it's heat protective, so stay cool, hydrated, protected from the sun. That one comes up a lot. We'll look out for others. It could also be weather related, so stay up to date with official forecasts or warning. Get on top of mold before it's a health hazard, because some of them are reporting about humidity and heat waves. Sometimes it's power related. Turn off printers and computers to conserve power. Okay, and then sometimes it's a bit ambiguous. So Queenslanders are urged to take precautions, and that's it. They don't say anything else. So that's what I've seen so far. Thank you so much for your time. Sorry to go over. And if you have questions, just come chat with me. Thank you, guys.
So just because we didn't get a chance to interview, we've got a very quick series of PhD presentations. Hopefully those people will make themselves available via email, or if you're in person, to answer any questions. So lots of small snappy presentations. So Mandroy is up next. He's online, Ella. So what are we doing? Oh, he's here. Hello. So we're going next, are we? Yes. When you're ready. Welcome.
Thank you. Morning, everyone. It is an honor for me to present my PhD thesis proposal entitled Temperature and Public Health in Queensland, a multi-index analysis of mortality and years of life loss. My name is Landry Pangreguan from the School of Community and History. My name is supervised by Dr. Simon, Dr. Brett, Dr. Chiwe, and Dr. Richard Franklin. Several studies have examined the association between heat and mortality across Australia. However, relatively few focus on Queensland. Moreover, only a limited heat health studies conducted in Queensland have analyzed the interaction between temperature and humidity, despite evidence that humidity exacerbates heat stress and significantly influences health outcomes. Additionally, no study in Queensland yet applied attribution analysis to differentiate human-induced effects from natural climate variability. So this attribution analysis is very new, and by doing this analyzed. For example, yesterday we have like 100 heat-related deaths, but how many caused by climate change and how many caused by natural variability? So the general aim of this study is to assess the impact of heat on mortality and years of life loss across Queensland. It has 4 objectives. The second is to identify heat metrics and to identify methods used to assess heat health relationship in Australia. This will be obtained by doing systematic literature review. So I'm on this stage now. And the last 2 is to examine heat health relationship in Queensland across the different climatic zones and across different demographic groups. And this will be obtained by doing analysis of primary data. So for the method, for the independent variable, we have heat, but we also interested to see the interaction between heat and humidity. And we have dependent variables, mortality, morbidity, and years of life loss. This association will be obtained by using time series analysis. And for this association, we will see the effect of modifiers of population density, climate type, ethnicity, rain covers, proximity to health services, age, and gender. And we will control for important confounding variables such as long-term and seasonal trends, air pollution, day of week, and holiday. And to differentiate how many deaths caused by anthropogenic climate change and how many caused by natural variability, we will perform attribution analysis. Sure. The strengths of this study, will be the first attribution study of its kind in Queensland. It combines mortality and years of life loss to capture both deaths counts and load. Examine diverse modifiers to identify at-risk groups and guide interventions. Integrate temperature and humidity to reflect real-world exposure, but it also has some limitations, such as using area level temperature may misrepresent personal exposure due to indoor time, air conditioning use, and microclimate differences. This is my references. Thank you.
Management. It's a really good overview of your proposed work. Seppi's next. Welcome, Seppi. Seppi is another PhD student, and she's going to tell us a bit more about her work.
You got to click the mouse, I noticed. Yeah.
Hello everyone, this is my work about developing a hybrid archetype framework for predicting indoor temperature, especially for vulnerable population. As all you know, climate change is increasing the frequency and intensity of heat wave all over the world, and in Australia, heat wave is the most dangerous natural hazard in comparison with different natural hazards such as flood, bushfire, and other hazards. It's really interesting that until it is projected that until 2066, the number of vulnerable people in Australia will increase. And therefore, because of the reason that people spend more than 90% of their time indoor, unfortunately, there is a huge gap between energy performance and thermal resilience in the building in Australia. And I think all of you experience these gaps in your homes. Therefore, it's really important to predicting indoor temperature for public health and urban planning. The relationship between indoor temperature and outdoor temperature is really complex and depends on different factors such as type of building materials, outdoor temperature and size, the location of the building, windows, and the orientation of the buildings. We need to have methods for predicting indoor temperature based on the literature review. We need to have a scalable, predictable, and accurate method for predicting indoor temperature in the city scale. Based on the literature review, there are different types of methods such as machine learning, deep learning, physics-based simulation, and statistical and time series methods for predicting indoor temperature, but all these methods rely on a sensor which is not applicable in the whole cities because of the maintenance costs, and the other reason is that vulnerable people, especially elderly people, are not really familiar with using a sensor and their application. And also it has a high cost when we want to applicable of a sensor in the whole city. I decided to use archetype method and grouping building based on the similar characteristic to predict indoor temperature in the whole city. To do that, previous archetype methods and traditional archetype methods has some limitations, such as it's really depend on the data, and it has a lack of automation and simplified classification. So I decided to use computer vision and use the eyes of the computer to detecting the material of the buildings, and have a new methods and novel method for developing the archetype. This method will be automated classification, alignment with the local condition, and improve the feature extraction to access the missing data. And this method will give us the more accurate for predicting indoor temperature. My project has 3 phases. First of all, data collection, which integrate the computer vision feature extraction with the metadata. And after that, by using the machine learning, I will integrate the data and clustering different archetypes. After identifying different archetypes in the city scale, I will simulate all different archetypes in the Hero software. I will simulate them in the Hero software and analyze the thermal performance of different archetypes. And after that, we will identify indoor temperature profile, overheating hours, and thermal comfort levels of different archetypes. The next step is validation of the model. In this step, we will validate different archetypes with the available buildings and compare is the model is accurate or not. And in the final step, we will prepare a different, we will use different available strategy to test our model to see in different archetypes which strategy will be useful. I don't have enough time. Continuing, but thanks for your attention. My research also have some contribution, and I think one of the most important contribution of my research is providing the long-term strategy instead of emergency response to heat risk. Thanks for your attention, and thank you very much.
Would be to get that all across. And I mean, I've been involved, I've seen your work a little bit, and it's kind of complex. So to bring it all down to that and to explain it in a way that I hope most of you can understand is fantastic. Okay, we have Anjali next, who's here today as well. Anjali will speak about it. No, all right. Well, I'll wing it. You're going to be good at this, Anjali. We'll just wing it. What can you do?
I think it's all in here, but then of course when I speak, it's going to be on.
But just make sure. Oh, yeah, okay, all right. So eventually my PhD is on heat, humidity and building local evidence base to inform health sector adaptation. So for those of you that don't know, Sri Lanka is in the South Asian region. It's a low middle income country. It's about the size of Tasmania, but with a population of 22 million people. It's got a tropical climate, so with average temperatures around 28 degrees and relative humidity of around 70 to 90%. And unlike parts of Australia where we have distinct seasons, this is what it's like pretty much all throughout the year. So there's not much local evidence about the health impact of heat in Sri Lanka, but there is this one study that was looking at extreme temperature indices over time, and it found that minimum temperatures have actually risen faster than maximum temperatures, and that the percentage of cold nights is also decreasing. Another study that looked at outdoor thermal comfort across the island found that heat stress has spread over time. And that was during the coolest month and the hottest month as well. Now, these research findings are backed by real-world articles from, news articles that showed that it's impacting human health and communities as well. So we know that heat and humidity is going to impact human health. But in Sri Lanka, non-communicable diseases contribute to 90% of the disease burden. And the leading causes of death are all heat sensitive. So together with an aging population, socioeconomic vulnerability, and changing climate, this is going to present challenges to the healthcare system. Now, national policies recognise that heat is a problem and that the need to build capacity is also a priority, but there's no local evidence to inform action. And most evidence we know comes from high-income countries with temperate climates, with little attention to humidity, and it's not translatable to low-middle-income countries in tropical regions. So what my research is going to do is to develop this evidence base of the impact of heat and humidity on mortality and non-communicable diseases, and then healthcare worker perspectives as well. So this is my research program. It's made up of 4 studies. The first is a systematic review looking at the role of humidity in heat health outcomes. So what's the evidence already available and what are the gaps? Studies 2 and 3 are quantitative studies. So that's using a time series regression analysis to again, look at the mortality of heat and humidity in Sri Lanka, and then the impact of heat and humidity on non-communicable diseases that are heat sensitive. So that's things like cardiovascular disease, type 2 diabetes, renal diseases, etc. And then the 4th study is looking at healthcare worker perspectives, and that's that's through focus group discussions. So what are frontline healthcare workers doing? Do they know that heat and humidity is an issue? And then what are the knowledge gaps? So these are preliminary results from my systematic review. So this is looking at the humidity. I found about 1,600 articles, and then after exclusion criteria, there was 32 left. And I'm yet to analyse my results, but I've got some descriptives for you. So of the 32 studies, the study data ranged from 1998 to 2021. Most of the studies were from China, 2 from Australia, and 2 were multi-country studies. The health outcomes that were studied were mostly mortality, hospital or emergency admissions, disease incidence as well. The vast majority of these studies include case crossover study design or a time series analysis design. And then, as you can see, only about 3 studies came from that tropical belt, which is, the tropical climates, humid, hot, and they're mostly low middle income countries. I will close. So my study is to develop, again, that local evidence base of epidemiological data to inform in Sri Lanka. And hopefully it will also answer that pesky question about humidity as well, which I know you're all wondering about. Thank you.
Yes. Okay, so we now move to Sarah, who's actually a PhD student who's currently doing the work in India. So welcome, Sarah. I'm not sure if you're there. Do you want me to stop sharing, Emma? Here.
Yes,
So-
I'm here, Shannon.
Okay, so if I stop sharing, can you share your screen, Sarah? Is that the way to do it, Ella? Yes.
Yeah, sure. That might be easier.
I already sent the slides.
Oh, did you? Okay.
Yeah, we have the slides, but
Do you want to share?
would you prefer to share your screen so you can control them?
No, I think you can share it, Ella.
Okay, no worries. I'll take care of it.
There again. There you go. Sarah, maybe you can introduce yourself while we're waiting to show your slide.
Good morning, everyone. I'm Sharat Chandra, a PhD scholar working under Shannon. So currently I'm in India for my field work. So as the title shows, I'm currently working on improving public healthcare system preparedness and response to extreme heat in an LMIC context. Now the research work is focused on India. Next slide. So why extreme heat in healthcare systems as an association is important? So globally, healthcare systems are becoming increasingly vulnerable due to climate change. And healthcare system as a component is one of the important aspects which directly contributes to reducing heat-related mortality and morbidity. And among the 8 core components of heat health action plans, research shows that this component, especially the healthcare system component, has been relatively under research topic, which could be an interesting focus area for extreme heat research. Next slide. So given this quick background, so what is extreme heat in healthcare systems literature actually showing? So firstly, there are 3 components of extreme heat in healthcare system literature. So we have a preventive aspect, we have treating aspect, and most importantly, we have a managerial and policy aspect. So the preventive aspect focuses on community health professionals and primary health care professionals. Treating, as everyone is aware, it focuses on various kinds of healthcare professionals who are directly engaged in handling the cases of cases overload of patients coming into the hospital setting. And managerial and administrative policies are those who frame and draft key guidelines and policies to implement during vulnerable conditions. So what the literature does not emphasize is it does not focus much on paramedics and pharmacists as a key components among healthcare system. Next slide. So what are the research gaps which have been identified from the literature? Firstly, there is low knowledge and awareness among healthcare workers about heat health, and there is limited research on the effectiveness of how training is being materialized in the context of heat health risk management. Nextly, we need to focus on all components. There is a skewed representation of certain components like primary, and some places it shows a tertiary focus. So there is not equal representation of all components. And lastly, we do not have much of understanding of how administrative and policy workers associated with healthcare system have a key role to play during extreme heat events. And lastly, lack of any research exploring how healthcare system and heat can be focused to the lens of paramedics and pharmacists. Next slide. So what makes a case to examine this research in the context of LMIC countries is firstly, as we are aware, LMIC countries do not have a robust infrastructural capabilities within the healthcare system, and they are overburdened already due to other competing healthcare issues like infectious diseases, malnutrition, and other kinds of aspects. And lastly, we do not have proper heat health action plans which focus on healthcare system as an important component. Next slide. So given this background, my overall research, which currently I'm undertaking in India as a part of my PhD fieldwork, focus on overall policy aspects of extreme heat. And nextly, how extreme heat is seen as a problem from the healthcare administrator point of view within the government sector, and how knowledge and perception of healthcare professionals is being undertaken from the government sector. And mostly my research focus on government sector because in an LMIC context, the government sector is the one which has a more overload of patients, and it has a focus, especially with respect to lower socioeconomic strata, which is actually the important group vulnerable to extreme heat. And lastly, my research also sees extreme heat as a problem from the community context through the lens of community health care professionals working in an LMIC context like India. So this is all my research about. And next slide, it's a thank you slide. Thank you so much for your patience.
Well done, all of you PhD students can keep your work to 5 minutes. Thank you so much for doing that. So our final speaker is Sarah Rogers. Sarah, are you there?
Yes, I am. Do you want me to take control so I can share my own slides?
Or you can just tell me when I can do it, whatever.
Okay, yeah, sure. Okay.
Yeah, I'll just stay here, might be faster, Sarah. So
okay, yeah.
we're on your introduction slide, so over to you.
Okay, all right. So hi, my name's Sarah Rogers and I'm a Masters of Public Health student at Griffith. And so my research is a mixed method study, exploring older adults' perspectives on the barriers and enablers to cool refuge access and use during extreme heat and heat waves in southeast Queensland. So next slide. So why do we need this research? Well, I probably don't really need to go back over that because it's been pretty well covered, but obviously older adults are more vulnerable to heat, and as climate change progresses, we're going to see more heat waves and extreme heat. So next slide. Oh, and then the next one after that, sorry, I'll skip that one. So research suggests that air conditioning is a valuable tool to stay cool and reduce heat-related health risks associated with heat waves. And unfortunately, access to home air conditioning can be scarce amongst vulnerable populations, especially older adults. Next slide. So in the absence of home air conditioning, the Queensland Health Heatwave Management Subplan recommends identifying and promoting places of cool refuge as a strategy to keep cool during heat waves. Next slide. And so that's just an example of a Queensland Health flyer and just giving that exact advice. And so the, which promotes, sorry, can you go back, sorry? Sorry, I've just got my notes of this. That's okay. I'll go start here. That's okay. I was just going to mention that when they when in my research, when I refer to cool refuge, we're talking about public air conditioned places like libraries, shopping centres and cinemas. There are also cool refuges that would be under a tree in a park or a public swimming pool, but this research is just looking at public air conditioned places. Okay, so next slide. So as well as informal cool refuges like shopping centres, more formal cool refuges known as cooling centres are widely used in the Northern Hemisphere. And they are usually activated during heat waves, providing communities with a designated place to go and sit in air conditioning, and they often offer additional services and activities. So in Australia, this is a relatively new concept, and it has been trialled in pilot programs in Western Australia and New South Wales, not that I'm aware of in Queensland yet. In New South Wales, some evaluation data that came out after their trial was that they found issues with related to accessibility, safety concerns, lack of awareness of cooling centre availability, and not reaching socially isolated populations such as older adults. Next slide. So the research questions aimed, sorry, next slide. Oh, go back one, did I miss one? No? Okay, sorry. Go back one then to the research. So public places with air conditioning, both formal and informal, can play a role in a multifaceted approach to reducing heat-related health risks in older adults. However, optimising that delivery and usage at the population level requires an understanding of the factors that impact their access and use, and so therefore that research aims to explore those barriers and enablers to the use of public spaces with air conditioning. And it also seeks to quantify the impact of identified individual social, economic and structural factors that influence its use. So next slide. So how are we going to achieve this? Next slide. So the research team will collect both qualitative and quantitative data from eligible participants. So we're currently in recruitment phase for qualitative data collection, which is using in-depth interview and focus group discussion on topics like heatwave and heat health, risk awareness, cooling behaviours, perspectives on informal and formal cool refuges as somewhere to visit during extreme heat and heat waves, and behaviour changes during power outages and how this may impact the seeking out of formal and informal cool refuges. So once qualitative data has been analysed, the key identified themes will then be used to formulate an online survey that will quantify these findings in the broader older adult population, and that's going to be available in the summer months of 25-26 and available to all eligible residents of Southeast Queensland. Next slide. So expected outcomes, next slide. So the expected outcomes of this research are to improve climate adaptation and resilience in older adults in Southeast Queensland through developing an in-depth understanding of the factors that influence older adults' access to and use of informal and formal cool refuges as a cooling strategy during extreme heat and heat waves. And it's hoped that this knowledge acquired may contribute to future policy and decision making related to cool refuges and their promotion in the community as a heat health risk reduction strategy for vulnerable populations. Next slide. The results of this mixed method study will hopefully be available in mid-2026. Thank you so much for your time. Thank you.
Thank you so much, Sarah, and thank you to all the speakers from this morning and to Ella for helping with undoing the glitches, and for all of your patience for while we have that outage. We're going to invite you now to have some morning tea on the deck. It's a beautiful evening out there, so please have a coffee and a bite to eat, and we're going to reconvene again at 11:10. Unfortunately, we've had to miss our Q&A session, so please hold any questions you have if we have some time right at the end, or if you wanted to find whoever spoke this morning, or follow them up at some point. Thank you so much.
Yes, probably morning tea. It's always a good time. Yeah, I've got real coffee. Would it be like a list long queue?
Yes,
Yeah. Exactly, yeah. It's really good. Yeah, exactly. To people like us who don't.
Some of my colleagues here, I know there is a few of us.
Sure that we
Right, too.
out of the, still tell there was a lot. Sorry, we weren't that loud. That's all right. Exactly.
I think Harry gets yeah, I know. Well, I'd love to have more. We got why did you do studies for the but you
Sorry, right.
mortality and morbidity.
I drove up there 2 weeks ago, but it was only driving around.
Oh, you're right, I'm going to do.
But I am looking out though for when they.
I'm looking forward to. Let's do it. Preparation.
That's because our house is yeah, everyone from Europe is.
Yeah, no, I think it was too distracting. Anyway,
Chat down. I get it on the second.
but now.
Yes, I should got a natural hazards, really like tiny $50 grant. So how do we get that?
So I wasn't expecting an immediate response.
We got
I was so
by
surprised.
professional translated.
I've got ways of building would have been safe. More like if people weren't dying, it's safe to do traditional.
You have to know.
Yes,
And I need to reach, I mean, like becoming more wealthy and build like great, big concrete,
part of the process is
like
also
fancy building. They're not, but you know, like, we're really damaged because it wasn't like adapted
you know, in the whole
climate. And so likewise, like we
that, I was hoping that have it.
and then just
Yeah.
random houses in climate and
I was like, you've never been the money after the project. And I love the people who made it.
yeah.
I have to get someone else, but it's fine. We got PhD, so I don't
We mentioned it yesterday.
Yeah.
Are you the fourth?
Yeah.
I mean, I will be, yes, but currently, like,
Yeah, so the standards are not.
Ella,
Original ones were great.
they're amazing, and we wanted to work with the same animator, but by the time she was like just getting which is fine, you know, the new person I'm kind of like giving it.
I'll do the analysis.
He teaches it, so he's really explaining to me the process.
Lovely to see you.
Don't know how animation works.
Right. So
Yeah.
these things are happening.
No, and he's really great. He's been explaining it as if I'm learning to be, you know, so really.
What else has gone on in your
Yeah, very, very keen to hear.
Well, presenting.
The science community.
I don't know the science. My background's as a language teacher. I got into COVID communication that's expanded indeed as another health issue. So
To move into it.
Yeah.
But it's like,
yeah.
I'm not, what I mean to say is like doing research is ridiculous. What I like to do is share the findings and translate them and communicate them.
Yeah.
Actually, I think that's.
Exactly, and then
And so we're doing.
actually very
Topics to some of the recent research on the ED impact.
Yeah, but teachers have their own struggles and
Yeah.
So now that I can tell them,
even having a space where they could.
research, and then we can use it to say, hey,
you know,
so ambulance has started.
Find it for yourself.
Day 3.
Yeah, and then you end up doing like some.
With what they can search, which is not. But because of this research showing.
if you look at some of these, I never have baccalaureate.
So I'm thinking I need
But we haven't really done the same yet within that.
Around that.
Framework. But yeah, we're we're into kind of chat. Yeah.
Opportunities, but.
Do you want to?
And it's amazing how what happens back the line really influences what comes through. Like we have a really hard.
I'll just put in.
Oh, cool. Yeah.
Wow. Yeah.
Yeah.
That's through all area.
Sort of downgrading.
Many
Senior cycles, so how you stop.
that haven't had any for years.
Yeah.
Where we had like 5 in the last season, you know, like work constantly and so many.
Now with like design, tech and digital.
But yeah, no, that would be super interesting. And if you could share your research
Not through the plan.
as well, like that.
Through things like digital modeling and advanced rendering and GIS.
Yeah. Yeah.
We're still,
Rules in.
let's say, working it out.
It's like,
Yeah.
I'm not, yeah, we're still working it out, yeah.
Not the right, they're not going. Did you guys also have in that round of?
Oh, gosh.
Finished at 8 this morning. I was like, it was like 3 to like, I think we're going.
Yeah. Yeah.
And that's what I was gonna say, when I started.
COVID, I had a. It's
We're
just.
still running the same.
Come on. Oh, I think I know, it's the whole thing with what they've recently done with.
Yes.
Done it's. Yeah. It's a big company.
Well, that's exactly what they did. They got new consultants. They reappraised every activity area, and everything. And what they did is they looked at research performance, student intake, overall financial position, retention, student engagement. And so these consultants came in all distributed like strong parts.
Great, yeah, I'm very happy to, I mean, we talked the other jurisdictions to try to share what really is doing.
Who's bringing in more?
Yes,
I don't need the money. I
Like,
go, why would it's one thing to use over and doing.
Actually, engineering, and they're like, we've had a mega successful year. We've brought in 30 million so far this year, and here's the distribution where the money went. It's like 28
afterwards.
parks.
Yeah.
Well, the rest of us got two.
Exactly. I'm on the research committee at the
In
moment.
between matches, to talk about where we're up to.
AEL
and
team was
Get
like,
your perspective, because we are, very much perspective from still as well.
I
And
know.
what's
huge
because
now.
we have a lot of
Anyone gets-
assumptions as well, we're sitting in this,
That's
we're
like
just in
a
the
huge
disaster
thing,
management
but-
branch, right?
And we
We
bring
work on all disaster, not just heat, and
We are actually.
we'll get sidetracked whenever there is a disaster to do with
Yeah.
that management
Our
side.
research, so yeah, but
But,
still, I feel like I've seen colleagues. in my
we have a lot
position
of assumptions,
around
like
the job
around
recently, and it's
on
an
discharge,
associate
what
professors, and I go.
information during a heat wave, clinicians are giving patients. Exactly, that's what we're starting to realize, and like, so working on understanding what are the gaps, like what reasons we use.
You're so strict.
Sorry, I was.
Like, we talk about these things, academia, you go.
Let's go get some.
I'm just gonna wait in the queue.
No, let's go.
No,
get tea together.
you take it to work.
Working with RCGP, Queensland, to work out, okay, what are the reasons? These are just primary healthcare.
Still there.
Because that's where actually we can do the most in terms of before people, stopping people arriving in ED. So we're trying to work on that as well. Yeah, it's
Reed, you work with the guys who.
really interesting to do.
Yes,
Just in Queensland, because I feel like sometimes I just don't go across the river.
Yeah, that's true. So we work really closely with all the disaster managers. So, and that's who you in contact with, the disaster manager for Metro. Joe, who, so we meet regularly with the disaster manager from the HHSs to share stuff. But as you know as well, because they're public structures, there's a lot of work going on. In one HHS, they will not share it.
Yeah.
And they will not, and there's nothing we can do about that, because
Still not used by anyone. But they're like, no.
so that is why, but I don't think it's a huge challenge on the heat health stuff. Heat health stuff, nobody is developing that much except for us, I guess, from what I've seen so far. So, and we share with everyone now. So I think that on heat health, it's possible. Like it's not very resource intensive. It's not like the development of a whole new training system within IMR or something, which is a challenge. But yeah, so I think because it's not that resource intensive. Anyway, can you give me your email address and then I'll flick you an email So then we can get set. Yeah, it is crazy. Coming in from it as fresh person from outside of health. I had no idea that we had just 16 separate businesses managing basically each hospital and health services managed by different businesses. It's crazy.
Second ED adopt something.
Oh, yeah.
The investment.
Yeah, not for us. Yeah. Well, the other part that I'm working on, the other casualty incident. And that is crazy in terms of the like completely separate conversations that happen within ICU, within ED, within any other. Like it's like, guys, this is going to be for all of us. Yeah, but it's very in that space I've seen a lot. Yeah.
I'm not doing communicable disease.
Yes. No, and it's true, and that's why the actual research is really cool because it's things that are find so many people are like, yeah, whatever. Despite the fact our buildings are terrible, as we were just talking about, despite the fact that climate change is real, which anyway, Queenslanders don't like. Anyway, the amount of stuff we have to change in our the way that we talk to not promote by not change. It's just right. Yeah. Wild. Yeah. And then no, but even because of even like things like this are like, we can handle it. It's totally fine. Stop telling us, stop giving us warning. Warning. We know it's like we're from Mount Isa. We are not as tough as we think. Like that some of these people have been saying now, understanding our self-perception of risk is even like I've been banging on about this for a while, but like, people who have comorbidities don't realise or know, like we're just not educated about then the impact of heat differently on our bodies. And even I hadn't realised, I was like, there's these people that don't think about their comorbidities. I don't have a thyroid, and that is one of the comorbidities that has an impact on your ability to meditate. And I just had I didn't know. I was like, oh, it's me too. I didn't even realise. So
people with comorbidities, they do.
Yeah.
They never self-identify as one of them. Yeah.
So that's like wild. So there's a lot of perception. No, we don't. Yeah, are you going? Oh, nice. Who's that? Oh, well, that's a shame. Yeah, no, we were, but it's just we Yes. Yeah. Oh, good. We'll suck you back in. Yeah, let's come into our vortex. Yeah. Sorry that's not the reality.
Yeah, I'm a little bit unstuck.
Yeah. Well, you're doing very well today. I slept all night. So, yeah.
There was one meeting at the moment and like how to kind of charge up here. But it would be really interesting to think about
I saw the videos. I saw the videos, yes. So it's like in January this year.
Yeah. So, yeah.
Yeah, quick numbers on, we'll just read it out to them, right, and then we'll prompt them questions. So it's like we can read it out to them. And what Ella is gonna explain it, right? Yes, so. We'll just be there.
We need to like push us in the right direction.
Some more. Actually, we don't, we just need to move. Yeah, we just have here, but we don't really do
anything that could impact the health system at all, or any like. Yeah, we were.
There's no.
But at state level, we only do it like
Some people need.
So. We did practically nothing on Japanese encephalitis as the disaster management approach because it's but we do monitor those countries and then we
Quiet. Is everything okay? Oh, yeah, I'm just.
Otherwise, email me, we can sometime, yeah.
been shared for a while and then so we want to share.
John Matthews, where are you based?
That's not for everyone.
Everybody.
I think that's why we'll have to keep it. Time together every so often.
There, but she's barely.
You say local.
Hello.
When I live in Normiston, but we're going to have a yarn. We're not that close to each other. She can always be welcome to live in the campus.
So I still have conversations, but nothing's come in terms of funding.
For an hour to chat.
Great. I'd like to. Okay, let's do that.
Today, we'll make it time today.
In December. Yep. That's with Brian Kelly. If you remember, he was at the end of our project. He was working with him. He's an RMIT, so we're going to try and lead that.
Across two institutions.
Yes. Yeah. But, it's a long dose of grants or a long shot, but we're going to get it.
Yeah. Well, it helps you. I always think those things that help you when you start with where do I want to go, what do I need to do, get you up to date in the literature. So, I mean,
thanks, Alan.
Hopefully you get some outcome from it. But you never know. Presumably technology.
So now I'm continuing to push there.
Yeah, good.
I'm on an MRFF application at the moment that's being reviewed. If that comes off, that might contribute a little bit of cash towards buying out some teaching.
Engagement.
And you'll come
to people I've had
engaging. It just looks too good. If you get it without to be
Yes.
Yes.
Yes. Yeah.
I'll go to the moon.
No worries.
It's every time, isn't it?
Got the hint.
Something else, should I? Background is interesting. Yes.
Yeah, health and aged care. I might define that here. A lot of different. Yeah, so direction.
Yep.
Leading programs and things. Yeah, then could got into communications and all of that. Yeah.
All public sector.
No, a lot of it not for profit. Yeah. So some of it public sector, so some hospitals, some the acute health and I've got acute health. Actually, well, there's also too. Sometimes to drive a more experience. Did you click online when you registered or in person? And I wonder if I should.
I can't remember. But anyway, well, I'll make sure that our Jennifer and Amber knows, so so at least the. However you go about it.
Yeah, you know.
Get some.
Where did you change it? That's me for me.
Oh, really?
Yeah.
Oh, me too. But you only got this, so you don't. Thank you. Oh, you've already. Like the end key doesn't work.
And then realize.
And I must have like I have to. So you've got to have.
Good. We'll get going with session 2 of the day. Ella, everybody.
That everyone should be back. I'm hoping.
Within this second session, we're going to be hearing from a range of speakers around Queensland heat health research and heat health research that is being undertaken in Queensland specifically. First of all, we'll hear from Hack O'Brien and Shannon again around the HEAL and NEMA projects, and then also from a team up at JCU, Townsville, and then again more locally from some academics from UQ. So we'll start off with Mahak.
Hello everyone, I'm Mehak. I work as a senior research assistant on the Ethos project, but other than that, since I'm transitioning into new roles, I've also worked as a project coordinator on this HEAL funded project, and HEAL stands for Healthy Environment, Healthy Environment and Living Group, which is funded this project, which is about identifying research needs and building research capacity in health action in Australia. Firstly, I'll like to introduce the project team, and it's quite a diverse team from all the states and jurisdictions across Australia, included the
Can you guys hear us online here?
Yep, Hannah's saying she can.
She can? Okay.
Yep.
Yeah, we're all good.
Sorry. Thank you. And now, hope you guys can hear me now. So I'll introduce the project team, starting from Shannon. She is the chief investigator on the project, with the other chief investigators from University of Tasmania, from Northern Territory, from New South Wales, from Victoria, and then we have Emma Becken from Sweltering Cities, and of course Fergus. And regarding the background and overview, I'll skip that slide because we have been talking about heat and health since morning, and we know it's an issue. But what's the project about, and what are the project aims? As we've been talking about heat and health and in various aspects, whether it's the vulnerable population, whether it's architect or built environment, there's a lot of heat research going around Australia. So the basis or the main aims of these projects were to enhance the research capacity, and for that to investigate the exposure on heat waves by bringing together various researchers across Australia. And in the next slide, I'll talk about the methods that we've been using to fulfill these project aims. The other thing was, I didn't change my glasses. That's all good. So I'll just map out the methods and activities along with the project aims. So for identifying the Australian, whatever heat and health work that is going around in Australia, we are doing a systematic mapping of the literature around that has been published since 2015, and it's a lot. We are currently in the data extraction stage, and we could see around more than 600 articles on the topic of heat and health, but it does include various EPI studies, housing, built environment studies. And then the other thing is for enhancing the research capacity, or to talk about what health impact heat has on the health and what solutions we can be aiming for. We did conduct a visual workshop on conceptualizing that in August this year, where we invited around 35 researchers from around Australia and gave them few personas, 6 personas from around Australia, and worked on Miro board to map down the impact of heat waves and then also the solution space. After the slide, I can show you a talk book that is currently a very draft form, and we'll be sharing it through HEAL and through our newsletters. And then we'll be hosting a virtual workshop in December with the policy people and researchers together in the room from across all states and jurisdictions to enhance the communication and between the researchers and the policy people, so that they know what are the needs of policy people can let us know about what are their needs, so that we can work as researchers can work on addressing heat health action and preparing them for preparedness and resilience. And then me and Karan would be presenting in HEAL conference this year about the lessons that we have learned from Ethos as a transdisciplinary case study. And this is the visual workshop where we use 6 different personas, and we did use Miro board to work as a team. And it was conducted by Haley, who is from Thoughts Drawn Out, and she's a wonderful visual facilitator. Shout out to her. And then this is something that she's in process of preparing, from taking the key takeaways into some visuals. And this is just a draft. We would be coming up with a talk book.
Thanks for that.
That's fast.
And a nice reminder for me personally of that project and where everything's at. So next we'll have Shannon Rutherford presenting.
This is another project that's just started. I'm really excited to represent our team. We have a multiple university team. We've called it HIMAC because as we know, we always have to have an acronym that actually is easy to say. The initial, I don't know if it's easy. Yes, the initial proposal says how are we reducing risk and how will we know? And it kind of stems from a couple of things. One is that we're having lots of conversations with local governments across Queensland, and there was a lot of storytelling around, or we're doing this, and then people were coming back and going, well, no one's doing this. And I was saying, well, there's some people are sort of setting up cooling centres, and others are doing work with vulnerable populations. So the idea of this project is to actually gather what local governments are doing, to look at the literature about what we know is working, because we now have like 3 or 4 years of very significant events in the Northern Hemisphere. And some of those publications are now starting to come out about what strategies are being used and what we know is working. But the other part of this project, which is kind of exciting, I'll just go back to the team, is to actually look at, trying to address this issue of the invisibility. So we don't see people on the streets dying of heat waves, like we might see people being injured from floods or fleeing from a bushfire. So we're looking at developing a methodology that allows us, and working with our colleagues in Queensland Health, to actually map every year what the previous summer was like. So what were the impacts
on heat and health from the previous summer. So it sounds like it should be easy, but getting the data and extract it out and working through the ethics and all those things make this quite an important task, but requires quite a lot of thinking. So they're the two main parts of our project, but I'll just go back up to our team because that's really important. So it's a Griffith Uni and James Cook University collaboration. So we're really excited to engage with James Cook, and we're going to have some speakers from James Cook in a minute. And then within the Griffith team, we've got Tony here, Jamie, who's an emergency specialist doing a lot of work in disasters, Monique, who you've heard from before, Mehak, of course, and Brett, who's our biostatistician. So we bring together a number of different disciplines and working with the James Cook team to deliver this 3-year project that's been funded through the Disaster Ready Fund, which is a national funding initiative administered through the Queensland Reconstruction Authority. It's quite a complex thing. So we're going to do lots of stuff. We're going to review the literature, of course. We want to know what's working. We want to then work with local governments and find out what they're doing, and then find out a bit more about what helps them do that. So do both a survey and some in-depth interviews. It'll be really important that we engage with our local governments. So those of you who are online, a big shout out. We will be coming and talking to local government very soon, a bit more about what we're looking at doing. We also have quite good representation. We've only just started with our advisory group from about 3 or 4 local governments across Queensland, and so we hope that they will help guide us in the best way of engaging around this topic. And we just had a meeting this week of the team, and we've had a great talk with Queensland Health, both the policy people and the statistician group, about how we're going to go through and get that data so that we can be doing those timely reports, to track how we're going over time, and we can, and also as a communication tool so that we can use that as a sort of platform to say, hey, it's hot again. This is what happened last time. Let's see what we can be preparing for in the next summer. And it's going to be lots of interesting outputs. Where we host this is a big challenge. Where do we put this stuff? It's the same with Ethos. Where do we put good work that needs to be disseminated and distributed? We'll be working on that. We have a number of national authorities that we're hoping will help to host this, or through our local government associations, for example. But there will be some good outputs that arise as the project continues. And that's the end for me. Thank you.
Thank you, Shannon. Very interesting work moving forwards. Next, we'll hear from PhD student Yohani, who I believe is in the room. Awesome. Thank you.
Hello everyone, thanks for having me today. I'm Yohani, from PhD student from the University of Queensland. Today I'm going to present one of my PhD study, the association between maternal exposure to ambient temperature and adverse birth outcomes and potential modifying effects of socio-economic factors in Queensland. So we already discussed about how temperature increasing in Queensland and how it impacted the vulnerable population. In my study, I'm focusing on pregnant women and neonates. So I'm skipping this a little bit. And why I'm doing this research? Because in Queensland, the maternal health research are limited, and especially most studies are focusing on how temperature affect on preterm birth and low birth weight and stillbirth. However, no studies have conducted on how temperature affect on congenital anomalies or neonatal deaths. And also, most studies are focused on Brisbane area, and limited studies conducted in the entire state. So, and also not many studies focus on how socioeconomic factors, socio-demographic factors impact on this. So therefore, my study investigates how average maximum temperature impact on adverse birth outcomes, specifically preterm birth, low birth weight, stillbirth, congenital anomaly, and neonatal deaths, and how the socio-demographic and economic factors influence on these relationships. So the study conducted at SA3 level, and our outcome interest was preterm birth, low birth weight, stillbirth, congenital anomaly, and neonatal deaths. We obtained this data from Queensland Perinatal Data Collection for the period of 2015 to 2022. Exposure windows exposure variables is average maximum temperature we obtain for covering the So the exposure windows covers the entire pregnancy period from early weeks of pregnancy and later weeks of pregnancy, as well as the second trimester, as well as third trimester, the key growth phases. And that's So the covariates we included in individual level as well as ecological level. Individual level covariates include maternal, age, marital status, country of birth, smoking status, and pre-pregnancy BMI. And then ecological covariates include education, income, employment status, and indigenous status. So this study, the analysis consisted 3 phases. The first one, I examined how this temperature and adverse birth outcome association in each SA3. In Queensland, there are 82 SA3, so I calculated the association for each SA3 using multivariable binary logistic regression. And then I pooled these all SA3 associations to determine the state level or overall effect of temperature and adverse birth outcome in Queensland. And then the third stage is I use meta-regression to determine how this modification effect of the socio-demographic and economic factors, how they influence on this temperature and adverse birth outcome relationships. So this study is approved, granted by the ethics approval was granted by the University of Queensland Human Research Ethics Committee. Data access was approved under PHA 2005 Queensland. Here, we employed over 450,000 cases for the period of 2015 to 2022 in Queensland, and most adverse birth outcomes reported in Queensland. From them, majority were reported like congenital anomaly, nearly 65,000 cases, followed by preterm birth, low birth weight. Stillbirth and neonatal deaths were limited in Queensland. And most of the, when we consider the maternal characteristics, the population, most of the people are around 25 to 34, around 60% of the study population, and majority were married or de facto relationship, and most are from Australia. And nearly 12% of the population reported smoking during pregnancy. And the exposure windows, we examined 5 exposure windows, early weeks of pregnancy, later weeks of pregnancy, and second and third trimester. So the all exposure windows show like pretty much similar temperature from 26 to 27. So first I will explain how SA3 specific associations varies during this study. So we, out of 82, we identified 40 SA3s which shows significant positive association with average maximum temperature for at least one birth outcome. And this table shows what are the strongest effects, where are the strongest effects. Usually we found that greater proportion of SA3s located in a remote and regional Queensland, specifically northern part of the state, exhibit higher associations. And also we also found protective effects as well, and most of the protective effects we found in the urban areas. So state level associations. So we found that when pregnant women exposure to high temperatures during the early weeks of pregnancy, 0 to 8 weeks, increase the risk of preterm birth. And when they expose high temperature during the later weeks of pregnancy, last 4 weeks and last week, increase the risk of congenital anomaly. Low birth weight increased during the second trimester, and neonatal deaths increased during the third trimester, and we didn't see any significant association with stillbirth for the exposure windows examined. And modification effects, we observe when in the lower income levels increase, it's significantly associated with the heat-related congenital anomaly, and indigenous status significantly associated with heat-related stillbirth risk. So why this study is important? This is the first study that examined how ambient temperature affect on adverse birth outcome like preterm birth, low birth weight, stillbirth, congenital anomaly, neonatal deaths across the state. And this is the first to examine the relationship between high temperature and congenital anomaly and neonatal deaths. And also, this is the first to examine modification effect of socio-demographic and economic factors on these temperature and adverse birth outcome relationships in Queensland. So finally, we found that exposure to maximum temperature may increase the risk of adverse birth outcomes in Queensland. And also this risk was higher in remote and regional Queensland compared to urban Queensland. And also socio-economic factors like income and indigenous status increase the risk of stillbirth, increase the risk of temperature and adverse birth outcome relationships. Thank you very much.
Next, we'll hear from Richard Franklin from JCU. And he's online, so do I need to do anything?
Dr. Is he going to do it?
Will the slides just go through, or how will it work?
It will be easier if you can just take over the screen. That way you don't have to say next slide every slide. Is that all right?
Yeah, that's fine.
And I'll just spotlight you as well.
And Richard's coming from the US.
Oh, no point spotlighting me because my camera is not working, unfortunately.
Never mind.
Something to do with Teams, not liking Teams. So.
Excellent.
Okay, is that working?
Yes, fantastic. Thank you.
All right, well, Watamuli, hello everybody, and thanks very much for having us. I'm going to talk through what has been a couple of projects that we've mashed together across a bigger sort of range of work that we've been doing in the heatwave sort of space. And it's been funded through the Queensland Department of Environment, Tourism, Science and Innovation in Queensland, and also the Fire Department, or QFES before that. I just wanted to put this up. So this is the time period that we're looking at, which is a 10-year sort of time period for a lot of this work. We're about to update it for the next sort of 5 years. But what you can see here is quite clearly that over this period of time, heat waves are increasing. So the number of heat waves that we've had across the state are increasing. So you can see it's a big issue for Queensland, and I wanted to point that out because this is why a lot of work's going on at the moment around heat waves. When we originally started, there was very little work in Queensland. There was no statewide sort of activity that gone on, a lot around Brisbane, which was really nice, but not so much in other parts of Queensland as part of it. So we were originally, as part of the original work, asked to get in and have a look at across the whole state and see what was going on around heat waves and what we could do. We've predominantly used a case crossover methodology where we've compared the heatwave day with preceding and post heatwave days on that same day across the 10 years with a little bit of adjustment that's gone in. And you can see here on this slide that we've used mortality data, ambulance data, emergency department data, as well as hospital admitted patients data to have a look at what's kind of going on. And so we've used a matching process to get it in. And it's been really interesting as we've looked through that. And I can talk more about it, but I won't bog you down the details around it. The other issue was trying to decide on what measure to use. A lot of the past measures have used a whole range of indicators around what heat wave is. We were quite lucky that the excess heat factor, which was developed by the Bureau of Meteorology, came out in 2015. We started looking at this in about 2018. So it hadn't been around for long, but we decided to give it a go. And really, this is the measure nowadays that is used to, at least by the Bureau, to indicate whether a day is a heat wave day or not according to their criteria from a meteorological perspective. And I want to put a little caveat around that, because it's not necessarily about the impact that it has on health, which is what we're looking at as part of our project, but it is their definition of that change in temperature that you see coming in. There are some real benefits with it. It makes it more locally relevant. It does stratify into sort of low severity, severe and extreme severity as part of it. So some value there as you kind of look at that as well. It does do some averaging. There have been a few issues across the years. Other people have done this, not using the same time frame that the BOM uses. And we've got some issues that as you get more hot days, the level for a heat wave goes up as well if you're using averages as part of it. So there's a few limitations, and it's really tough to kind of communicate what this excess heat factor means to the public. So giving you our overall findings that we've looked at, basically there is a 13% increase in ambulance calls on heatwave days, about a 9% increase in presentations, which then relates to about an 8% increase in emergency departments, 8% in hospital, and 5% increase in deaths. So you can see that this is significant, particularly for the ambulance and ED, where you're seeing about a 10% increase on heat waves days. And so therefore, for every 10 people you have, you'll probably need an extra one, because it doesn't discriminate time of day or anything like that around it. Also, overall, most conditions are impacted by heat waves, but you can see here that neoplasms, mental health, some of the nervous system stuff, as well as this kind of catch-all other group go into it. But you can see things like external causes, some musculoskeletal, a little bit of circulatory system as well. So interesting, and this is in the deaths. And what's interesting as we look at some of these, you'll probably pick this up as well, is that we do see a change in the different primary causes as we look at the different data sets, or at least the ones that are stronger. So you can see here in the hospital, we've got ear and mastoid and endocrine coming through, and interestingly, respiratory dropped right down. So there's something going on there between the hospital and deaths, and that needs a little bit further examination. But really, again, you can see across the board, most of the ICD codes went up. Circulatory didn't go up by very much, which is also interesting, and that needs further looking into exactly what's the different subcategories in that. Again, in the emergency department, you can see endocrines come through. And so again, you see some of the respiratory stuff's back in again when you look at it in emergency department. So again, that's why I say to you, the story is really interesting, because obviously, we're seeing it in the emergency department, we're not seeing it in the hospitalisation, but we're seeing it back again in the deaths. So there's something going on around the respiratory where it's either well managed or people will die as part of that process, or they need the emergency department. But again, you can see lots of movement across, a couple of things where it's not moving, but interestingly, the cancer stuff doesn't seem to go up here. If anything, there's a little bit protective, but you can see the large confidence interval. So it is a little bit all over the shop, and so further work is required to try and understand in a little bit more detail which of these causes or sub-causes are part of it. The other thing that is interesting, and this kind of goes to a lot of the work that's being done talking about sort of chronic disease and the impact that has, we use the number of recorded ICD codes as a bit of a proxy for people being more unwell. And you can see really the more ICD codes they have, the more likely they are to be impacted by heat waves as part of it. So again, that aligns with what we found during COVID with those that had other underlying chronic diseases. It's just tough for the body to recover or maintain its homeostasis, particularly when you're hit by heat or some other infection. The other thing we've been looking at is, does it just pop up for heat waves and then disappear? What this is showing, this lag effect that you can see here, is certainly on the heat wave day it is higher, but you can see here for ambulance calls it remains for the next couple of days, drops down again, and then kind of stays constant for at least 10 days. Emergency department, you can see, just drops off slowly, and it's heading towards at day 10 towards back to what you would expect on those days. So again, interesting that obviously high heat is impactful in this as well. The other thing we've been looking at is some of the underlying things. We looked at this one around drowning and ambulance presentations as well as hospitalisations. And again, you can see the number of people drowning go up during heat waves. So no real surprise, because when you're hot, you're going to try and get cool as part of the process. And one of the ways that people are doing that is obviously going to water locations. And what that means is that we're seeing an increase in the number of deaths because of that, and also a significant increase in the number of ambulance calls. And you can see there for females, on the bottom right-hand side, we see a 36% increase on heat waves for drowning-related incidents of females as opposed to non-heat wave days. So very interesting that we're seeing this kind of come through as part of the work that we're doing. There are a number of challenges with the work that we're doing. Obviously, we don't have a direct link between heat waves and people's ill health. We're using sort of association as part of the process and looking at some of the excess morbidity or mortality that comes through. But we are doing it across the whole of Queensland, and we are taking into account things like acclimatisation and previous temperature that year. We are going to do a little bit more work around this to look at diurnal, look at average temperatures, and look at overall temperature as well. We suspect that EHF is probably pretty good up to a point, and then once you probably get over the human homeostasis point of 37.8 degrees, you're then going to see some issues. Well, that's our hypothesis with kind of what's going on there and the impact that has on EHF. It doesn't also take into account humidity or air quality. We've got some challenges with air quality measures across Queensland, and so that's a challenge. We do need to look at length of heat wave as well, and we need to look at when the heat wave occurs, early in the season or later in the season, whether that makes a difference as well, and also continuing severity. So is long, low level any different to long, medium or high, and what happens as you jump up and down between those categories as well. And also we've got some challenges around just the increasing population in Queensland, which we see, which means putting more impact on health services, and we're also seeing that for the older age group as well. So you've kind of probably picked this up as I've gone through, but we're certainly seeing some challenges around is EHF the correct measure? Humidity and ambient temperature need to be looked at. We need to look at the different climate zones. We need to look at condition specific. We need to certainly look at more service and flow through of the service as we see people move through. We need to look at some heat island impacts and human behaviour and what they do. So this is the QR codes for our publications. This will be available afterwards, so you can check them out. But thank you very much for listening. And we really do want to thank a whole lot of other people that have been involved with this. This is very much a team effort that goes through, but I particularly want to thank Jodie and Maria who kicked it off, and Jodie who continues to keep us on our toes around the heatwave work. So thank you to everybody, and thank you for listening.
Are you able to stick around for the last bit, or have you got to duck off something else?
No, I'm happy to stick around.
Fantastic. So we might just keep any questions till that last session. Thanks, Richard.
Thank you, Richard. We're now going to hear from Hannah Mason, who is one of Richard's PhD students, also from JCU. Hannah, I believe you should be able to take control, and slides are there. Awesome.
Yes. All right. Sounds good. Can everybody hear me on your end?
Yep. Yes.
Happy days. Okay. Excellent. Well, thank you so much for having me. I'm just going to kind of whiz through my PhD work. It's very much connected to the work that Richard just described. So we're going to talk kind of about how this is different and what are the things that we want to pull from it. So my PhD project is about unpacking the impact of heat waves on Queensland's aging population. And as we've heard this morning already, this is definitely a population of interest here in Queensland. So I'd like to thank my primary supervisor, who is of course, Richard, and my secondary supervisor, who is Dr. Nathan Dawes. So what we've learned about the impact of heat waves across age groups when we look at the data for the whole of the state is that the picture is not actually super clear. We keep kind of hearing and talking about the fact that, you know, our older age groups are our most vulnerable. But when we were looking specifically at the emergency department, we were actually seeing that some of kind of the lower age groups had similar risks to the 85 plus group. We saw that the 80 to 84 were kind of at, you know, one of the lower risk groups. Hospital admissions, you kind of see from 80 to 84, they're going up. This hospital admissions is also split by recorded gender. So there's some interesting things going on. And I guess the purpose of this kind of project is to unpack who of our older adults is actually vulnerable And, do we need to break this down more than just saying older adults are vulnerable? We also looked at some community level factors using heat wave vulnerability hospital data when we were working with the Queensland Fire Department. And this is just kind of showing with the hospitals, the darker red areas on the left side graph are, the highest incidence of heat wave hospital admissions in comparison to non-heat wave. And then the red on the right-hand graph is the communities that have the highest proportion of older adults. And they don't marry up very well. They don't really sync very well, which is showing us that kind of this impact and older adults in the community, it's not very clear, and there's more work that needs to be done. So, of course, like any good research project, we're kicking off with a literature review. We want to know more about the risk factors and the protective factors for heat wave related health risks for older adults. We're going to identify and synthesize these drivers, and then we're hoping to kind of come up with a conceptual map of risk and protective factors that can inform our subsequent studies. And then we're going to move on to some exploratory work. So our question is about how heat waves impact health outcomes and emergency presentations among older adults. So we're going to work with some data from Queensland Health for about 2019 to 2024, which will be kind of a new lot of data. And we're going to explore both primary and secondary diagnosis. As Richard was talking about, we're really interested in kind of this multi-morbidity effect. We're also going to look at the different heat wave definitions and see how those have an impact on how we kind of declare risk, and then also determine kind of an optimal age cutoffs when we're talking about older adults at risk for heat waves. I think, generally it's kind of 65 plus, but our question is, do we have to refine that a little bit further when we're talking about heat wave risk? Then we're going to move on and do some spatial analysis, which I'm really excited about. We are working with a gentleman from UQ on this, and we just want to kind of map geographic variation in heat wave related morbidity and mortality across the state. We want to find kind of those hotspots or clusters for older adults and examine associations between area level vulnerability indicators, so things like SES in the community, access to services, etc. And we're hoping to identify kind of some high risk regions so we can think about, what are those LGAs doing, how are they accessing services, etc. Paper 4 is going to be about mental health outcomes for older adults, particularly when we conducted our first literature review. We saw a lot about dementia and other mental and behavioral conditions. So we really want to kind of tease that out and see what kind of temporal, demographic, and regional patterns exist for older adults. And again, of course, this is to provide some evidence to guide some service planning for older adults with cognitive and psychological vulnerabilities. And then paper 5 and 6 is going to be putting on my qual hat. This is definitely a multi-method kind of PhD. So we want to do some focus groups. This will definitely be guided by the evidence that's already been collected by the Ethos project through Griffith and all of this other great work that's going on, just so we can kind of see what's next, what do we still not know, and kind of how can we move forward. So in conclusion, altogether, this PhD is helping to build towards a comprehensive understanding of how and why heat waves impact older adults in Queensland by identifying the drivers of vulnerability, quantifying health impacts, mapping spatial patterns, and exploring behavioral responses. Thank you.
Thank you very much, Hannah. Looking forward to seeing that series of projects come to light. It's really interesting work. Our final presentation in this session is going to be from Patrick Emalati from UQ. He's also online. So Patrick, you should be able to take control and put your slides up. Perfect.
All right. Okay. My name is Patrick, and thank you for the opportunity. My presentation is titled Human Vulnerability to Heat Wave in Australia, Countrywide Suburb Level Longitudinal Study. Hello?
Patrick, sorry, we can see your notes page. Yeah, you might need to get into presenter mode or something.
Oh, okay. Can you see now?
Yeah, that's better.
All right. So this is longitudinal study that was conducted across Australia at statistical area level 2. For simplicity, we call it SABEP. This study was supervised by Associate Prof. Zumfun as my primary supervisor, and Nick Osborne and Dr. Zue. Before I proceed, this work has resulted in 4 publications. The first publication helped us to identify the heat wave vulnerability indicators. The second one helped us to construct the heat wave vulnerability index, and the third one validate the vulnerability index. So the final one was a interview-based study. It's currently under review. So to start with, heat wave is the risk of heat-related death is increasing in Australia. Study shows that over 300 deaths were linked to heat. And there are several other epidemiological studies showing increase in heat-related deaths in Australia. Despite all these evidences, the understanding of heat wave vulnerability at national level, and particularly how vulnerability changes over time, is still limited in Australia. So the aim is to assess heat wave vulnerability across Australia and to explore the factors influencing the vulnerability. Fortunately, we were able to design this study using census data from ABS for 2011 to 2021 at every 5-year interval. Of course, we included health data and land cover data as well. So we selected following, this was indicators, were 40 indicators that was used to construct the index, and it was selected following our scoping review. We applied several statistical analysis, particularly principal component analysis, to help avoid the multicollinearity that may exist among the variables, especially socioeconomic and demographic indicators. And we conducted cluster analysis and also performed a regression analysis as well. So this is the discrete analysis of all the 40 indicators that were used in our vulnerability from 2012 to 2016 to 2021. I understand it's difficult to read these numbers. So yeah, in overall, our vulnerability score was ranked from 1 to 6, 1 showing the least vulnerability and 6 showing the highest vulnerability. So we could see that from the top 2 highest vulnerability scores, which is 5 to 6, I'll prefer 5 because it has a large number of suburbs or SA2s. So you show that it showed that there was some trend of decreasing vulnerability at national level, that's across Australia, and also at the greater capital cities, which are the capital cities in Australia. So vulnerability seems to decreasing over time, but the trend is not really that clear. We found that vulnerability, those high cluster of heat vulnerability are the northern part of Australia, and this was consistent across all the 5 consecutive years from 2011, 2016, 2021. But in the south, east, and west part of Australia, we saw that vulnerability is decreasing over time from 2011 to 2021. We continue analysis, look at the capital cities from Sydney, Melbourne, Brisbane, Adelaide, Perth, Hobart, and Darwin. We found that generally vulnerability is also decreasing, but it seems that cities like Melbourne, especially in the southern part of Melbourne and northwestern part of Adelaide, still showing high clusters of vulnerability. But in general trend, vulnerability is decreasing from 2011 to 2021 across the cities. So here we try to identify the factors that are influencing the vulnerability First, by modeling the heat-related death across the SA2s and regressing the individual vulnerability factors with heat-related death. We found that during the year 2016 to 2021, within the 10-year period, we see that heat-wave vulnerability factor comprising of low education, SA2s with low education, low income, high diabetes, and low healthcare professionals were associated with heat-related death. But previously, the risks were at vulnerability factors that consist of people who are 65 years and above and living alone, or can call it social isolation. So consider in 2011, the vulnerability, the risk in terms of related, the association between vulnerability and the heat related that was driven by people who are 65 years old and above and who are living alone. But the trend has changed to our current time within 2016 to 2021, where the vulnerability is now being driven by suburbs, SA2 is low education, low income, high diabetes, and lower healthcare. This clearly shows that this can be explained as increasing in aged care industry in Australia over the past 10 years, as now the increase in aged care industries means more people, older people are now being moved from their individual homes to the aged care facilities for proper care. So in that manner, they are being, in terms of risk of heat-related death, is showing decrease. And we also try to understand how the different heat wave, categories are influencing heat wave vulnerability. Among low intensity, severe, and extreme heat, we found that extreme heat shows strong association with heat-related death. So in overall, heat vulnerability is evident across Australia with higher vulnerability in the northeast and lower vulnerability in southwestern Australia. Previously, elderly people and people living alone were having higher risk of heat-related death or heat vulnerability, but the trend has shifted to those with low education, low income, high diabetes, and healthcare professionals. So heat wave vulnerability showed a positive association with extreme heat days. So in future, we look at validating vulnerability index at national level using cause-specific data like cardiovascular death and also hospital admissions as well. And we're also looking at projecting our vulnerability under different climate change scenarios to understand the future vulnerability in Australia. And also we focus more on the SA2 level, intervention, heat wave intervention study, and also to delve more into longitudinal heat wave vulnerability in Australia. Thank you.
Thanks very much, Patrick. That concludes our presentations for this session. We're now going to move on to a panel discussion, talking more broadly about Queensland heat health research, learnings and future directions.
So if we can just invite Tony and Steve and have those people and some of all the PhD students, if you can fit or not. The chance for people to ask questions and also potentially those online, those of you who presented online, if you can be available for a question, to not only ask single questions about individual research, but as a collective, you're lucky you've got a whole heap of researchers together. For people not working in research, but maybe being the beneficiaries of research or interested in driving action and change, what sorts of things do you see as needing to happen in order to continue the progress that we've made so far? So the floor is open. For those of you online, I think Ella is in the audience, but someone's tracking the Q&A. Yes.
We do have a few questions as well.
Okay. Do you want to start with them to get the ball rolling for the online audience?
Yes.